merupakan dosen pilihan dan lulusan-lulusan terbaik.
Sebuah kebanggaan bagi kami dapat mendidik dan mempersiapkan para Ahmad Yani muda sebagai generasi penerus kejayaan bangsa Indonesia.
Ketua Program Studi Teknologi Bandara Universitas Jenderal Ahmad Yani Yogyakarta. Program Studi Teknologi Bandara memiliki visi menghasilkan teknisi pelayanan daerah yang unggul dan terdepan di tingkat nasional, serta mewarisi nilai-nilai perjuangan Jenderal Ahmad Yani. Misi dari Prodi Teknologi Bandara adalah yang pertama melaksanakan pendidikan di bidang teknologi bandara yang bermutu dan responsif terhadap kemajuan ilmu dan teknologi. Yang kedua, melaksanakan kegiatan penelitian yang unggul di bidang teknologi bandara berdasarkan ilmu pengetahuan, teknologi, dan budaya bangsa, serta menghasilkan produk-produk inovasi. Yang ketiga, melaksanakan pengabdian kepada masyarakat di bidang teknologi bandara yang berdaya guna dan berhasil guna. Yang keempat, melakukan kerjasama yang berkelanjutan dengan stakeholder di bidang pelayanan daerah untuk mewujudkan daya saing terbaik. Kelima, menyelenggarakan dan mengembangkan manajemen yang baik dan mandiri, serta yang keenam, mendalami dan mengembangkan nilai-nilai perjuangan Jenderal Ahmad Yani untuk diterapkan oleh sivitas akademika dan pendukungnya. Untuk itu, kami mengajak mari untuk bergabung dengan Prodi TPD untuk menjadi teknisi pelayanan daerah yang profesional, unggul, dan terdepan di bidang pelayanan daerah. Dan up-to-date. Pencapaian yang didapatkan dari laboratorium IMLPD yaitu mahasiswa mampu melakukan pemeriksaan uji saring terhadap infeksi menular lewat transfusi darah meliputi HIV, hepatitis B, hepatitis C, sifilis, serta malaria untuk daerah endemis. Dengan menggunakan metode imunokromatografi atau rapid test, enzim link immunosorbent assay atau ELISA, chemiluminescence immunoassay atau CLIA, nucleic acid amplification test atau NAT, serta mampu mengatasi permasalahan yang ada di uji saring infeksi menular lewat transfusi darah. Sedangkan pencapaian yang didapatkan dalam laboratorium serologi golongan darah yaitu mampu melakukan prosedur pemeriksaan golongan darah ABO dan rhesus, uji silang serasi antiglobulin test, penanganan kasus dalam pemeriksaan golongan darah, pemeriksaan screening dan identifikasi antibodi dengan menggunakan metode tube test dan gel test, serta sistem pencatatan dokumentasi dan pelaporannya.
Langkah awal sebelum pengambilan darah yaitu seleksi donor, di mana seleksi donor ini bertujuan untuk mendapatkan calon pendonor yang memenuhi kriteria kriteria untuk melakukan donor darah. Jika pendonor memenuhi kriteria untuk melakukan donor darah, maka akan dilanjutkan dengan pengambilan darah. Untuk pembelajaran mahasiswa telah disediakan fasilitas ruangan yang setara di PMI dan jejaring kesehatan lainnya pada ruangan seleksi donor dan ruangan pengambilan darah. Pencapaian pada seleksi donor yaitu mampu melakukan seleksi donor secara mandiri meliputi identifikasi, anamnesa awal, pemeriksaan kesehatan sederhana, dan pemeriksaan golongan darah serta pemeriksaan kadar hemoglobin. Pencapaian dalam pengambilan darah yaitu mampu melakukan penyadapan darah secara mandiri untuk kepentingan transfusi dan terapi di bawah supervisi dokter dengan menggunakan prosedur standar dan mengetahui jenis reaksi donor serta cara penanganannya.
Sebelum mahasiswa mengenal apa itu transfusi darah, mahasiswa diberikan mata kuliah ilmu dasar teknologi bank darah, di mana di dalam lab ini TPD, mahasiswa melakukan pemeriksaan sel secara mikroskopis, kultur bakteri, pemeriksaan tekanan darah, cek hemoglobin, serta pengambilan sampel darah menggunakan spek, sehingga menjadi pedoman dasar bagi mahasiswa untuk pembelajaran selanjutnya.
Selain lab IDTPD, ada pula lab komponen darah. Di sini mahasiswa diajarkan untuk mengolah darah menjadi beberapa komponen darah seperti PRC, TC, FFP, dan LP, serta komponen lainnya. Mahasiswa juga diajarkan untuk menghitung komponen serta komposisinya setiap komponennya.
Universitas Jenderal Ahmad Yani Yogyakarta merupakan lembaga pendidikan di bawah Yayasan KTK Eka Paksi TNI Angkatan Darat, terbentuk dari penggabungan Stekas dan Stenik Jenderal Ahmad Yani Yogyakarta. Universitas Jenderal Ahmad Yani Yogyakarta bersesanti Aditya Mahatma Daksa, yang bermakna senantiasa menghasilkan lulusan yang pandai dan bijaksana, berjiwa besar, cakap dan ahli.
sebagai bagian Universitas Jenderal Ahmad Yani Yogyakarta yang dimiliki oleh TNI Angkatan Darat dan membawa nama besar Jenderal Ahmad Yani, Fakultas Teknik dan Teknologi Informasi diproyeksikan menghasilkan lulusan wirausahawan teknologi di era ekonomi digital yang bukan hanya unggul secara akademik, namun juga berkarakter dan memiliki jiwa nasionalisme. Ditunjang dengan fasilitas yang lengkap sesuai dengan kemajuan teknologi, kurikulum yang selalu up to date, dan dosen pengampu yang berkualitas, Fakultas Teknik dan Teknologi Informasi Universitas Jenderal Ahmad Yani Yogyakarta berkomitmen mempersiapkan para Ahmad Yani muda di era ekonomi digital. Saat ini menyelenggarakan 4 program studi, yaitu Prodi Sistem Informasi S1, Prodi Informatika S1, Prodi Teknologi Informasi S1, dan Prodi Teknik Industri S1.
Fakultas Kesehatan Universitas Jenderal Ahmad Yani Yogyakarta saat ini menyelenggarakan 8 program studi, yakni program studi pendidikan profesi nurse, Prodi Pendidikan Prosesi Bidan, Prodi Keperawatan S1, Prodi Kebidanan S1, Prodi Farmasi S1, Prodi Kebidanan D3, Prodi Rekam Medis dan Informasi Kesehatan D3, serta Prodi Teknologi Bank Darah D3. Ditunjang dengan fasilitas yang lengkap dan terstandar sesuai dengan kompetensi keahlian, serta semua prodi telah terakreditasi oleh LAMPTKES. Fakultas Kesehatan Universitas Jenderal Ahmad Yani Yogyakarta siap mendidik dan mempersiapkan para Ahmad Yani muda di bidang kesehatan sebagai generasi penerus kejayaan bangsa Indonesia.
And for the participant, please rename the username with the format that's written in the chat forum. So please change your username into institution and then underscore and your full name. Thank you so much.
Assalamualaikum warahmatullahi wabarakatuh. Selamat siang, salam sejahtera untuk kita semua. Shalom, Om Swastiastu, Namo Buddhaya, salam kebajikan. Good afternoon. I would like to welcome all attendees who have attended the second International Webinar Unjaya Blood Bank, Technology in Apheresis 2022. Good procedure in blood treatment for patient safety, held by the Blood Bank Technology Student Association at Jenderal Ahmad Yani University, Yogyakarta. The Honorable Rector Jenderal Ahmad Yani University, Yogyakarta, Dr. Andes Joko Susilo, STMT IPU, Dean of the Faculty of Health, Jenderal Ahmad Yani University, Yogyakarta, Ms. Ida Nursanti, SCAP, Nurse, MPH, Department of Blood Bank Technology, Universitas Jenderal Ahmad Yani Yogyakarta, Ms. Francisca Romana Sri Supatmi, AMDkes SKM MSc. Our moderator, Ms. Anastasia Suci Sukmawati, SCAP Nurse MNG. For the first speakers, Dr. Teguh Triyono, MKes SPPK, Konsulen. For the second speakers, Dr. Mendes Pinto, SPB. For the third speakers, Mr. Hans Friendly, MD PhD. For the fourth speakers, Dr. Diah Artini, MSc SPPK. For the five speakers, Dr. Diah Nur Pratami, MSc, and the last speakers, Ms. Francisca Romana Sri Supatmi, AMDkes SKM MSc. On this happy occasion, allow me as the Master of Ceremony to introduce myself. Hello, my name is Lutfika Sukma. I am a student from the Blood Bank Technology Study Program at Jenderal Ahmad Yani University, Yogyakarta. Ladies and gentlemen, before starting the event, we will read the agenda as follows. For the opening, Indonesia Raya Anthem and Mars Unjaya, report from the Chairman of the Committee, remark from the Rector of Unjaya and Direct open the International Webinar, Dr. Andes Joko Susilo, STMT IPU. Now, we entering the first event, Indonesia Raya Attempt and Mars Unjaya. The participants to remain calm.
Indonesia
For the next, report from the chairman of the committee to Ms. Martawati Pohilihu. Place is yours.
Assalamualaikum warahmatullahi wabarakatuh. Thank you for the opportunity that has been given to me. First of all, I would like to thank you Allah Subhanahu wa Ta'ala for giving us blessings so that we could hold this activity because of mercy. We're sitting in event the second international webinar Unjaya Blood Bank Technology in Apheresis, which has as its theme good procedure in blood treatment for patient safety in good health. I would want to offer my sincere gratitude to everyone who helped make this occasion successful. I'd want to extend my gratitude to Dr. Andus Joko Susilo, STMT IPU, who stands as Director of Unjaya. I would like to thank Ms. Ida Nursanti, SCAP NS MPH as the Dean of Health Faculty Unjaya, and also Ms. Francisca Romana Sri Supatmi, Kes MVP HD. For speakers, Dr. Dia Artini, MSc, SPPK. Five speakers, Dr. Dia Nur Pratami, MSc. And the last, Ms. Francisca Romana Sri Supatmi, AMDKes, SKM, MSc. The webinar international include 541 participants participated in this webinar with the following details from Indonesia, Timor-Leste, and Singapore. This activity is supported by PT Transmedic Indonesia. Hopefully, this activity will benefit all participants and bring about change for the better in the future. So that I can convey, sorry if there is a delivery that is less pleasing to the words and behavior. I would like to thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. And the last remark from the Vice Rector of Academic of Unjaya and Direct open the international webinar, Miss Weni Safitri, SCAP Nurse MNS. Place is yours.
Hello everyone, good afternoon, ladies and gentlemen here. Assalamualaikum warahmatullahi wabarakatuh. First of all, in this special opportunity, I would like to start by welcoming everyone, our speakers, Mr. Hans Freeling, MD PhD from the Netherlands, Dr. Mendes Pintos, SPB from Timor-Leste, Dr. Teguh Triyono, MKes, SPPK, Dr. Dia Artini, MSc, SPPK, Ibu Iva Agustina from Indonesia, and also last but not least, our beloved Head of Blood Bank Technology Program, Ms. Francisca Romana Sri Supatni, Master of Science. I also would like to welcome the Dean of Faculty of Health Science, lecturers, students, and health practitioners, and also our external participants, including students, also lecturers, and other health practitioners in blood bank technology. I welcome you to the second international webinar in apheresis of Punjaya Blood Bank Technology Program. And as we know that the aim today is we're gathered here to share knowledge regarding apheresis, as well as good practices in Indonesia and also in Netherlands and also in Timor-Leste. I believe that this webinar is very necessary and important for students, lecturers, and also health practitioners of blood bank technology to excel the quality of blood and then also blood donors as well as to the patients. With huge energy and enthusiasm that I'm seeing right now, I believe that we will end this webinar with plenty of inspiration, hopefully. And I would like to thank everyone here who has agreed to share their experiences, ideas, viewpoints, and also with us here. And we look forward to hearing all these interesting presentations from the speakers, and hope you all will contribute your view and also good ideas to the subsequent discussions later. Let me just end by this speech by welcoming you all once again to our webinar. Enjoy your time and good luck. Thank you, everyone. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you for Ms. Weni Safitri for the remark and open the international webinar. Now, we enter the main session of this event from Ms. Anastasia Suci Sukmawati as Nurse MNG will guide you as moderator. Before, I will read curriculum vitae from Ms. Anastasia Suci Sukmawati as Nurse MNG. Ms. Anastasia Suci Sukmawati for the qualification Bachelor of Nursing, Universitas Gadjah Mada, Yogyakarta, Indonesia, and Master of Nursing, filed University Adelaide, South Australia. Employment, professional experience. First, lecture, School of Nursing, Universitas Jenderal Ahmad Yani, Yogyakarta, Indonesia, April 2009 until now. Previously worked as a medical staff in International Organization for Migration United Nations Agency, editorial member, reviewer Jurnal Kesehatan Stikes Prima Bukit Tinggi, reviewer Jurnal Ilmu Kesehatan Darmas Indonesia, January 2021 until now, editorial team Journal of Apply Nursing and Health, July 2021 until now, peer reviewer Careers Journal of Medical Science. Next, for the achievement, research grant from Universitas Jenderal Ahmad Yani, Yogyakarta, 2022, Australian Grants Scheme Alumni, 2021, research grant from the Ministry of Education, Culture, Research and Technology, 2020, grant from Kanagawa Institute of Technology, Japan, 2018, Best Oral Presenter in International Conference Jember University 2018, Australian Development Scholarship 2040, Grant for the Ministry of Education, Culture, Research and Technology 2012, publication. Mr. Suchi has published several research articles. Please check here archive ID 0000274022013 or here scope ID 57202300163. For Miss Suci Anastasia, it's time to you to guide us. Thank you.
Okay, thank you, Mbak Lutfika. Okay, good afternoon, everyone. Before we are going to have our, before we are join the speakers, that will be great for us to have documentation sessions, because I'm pretty sure that, I'm pretty sure, Miss Weni Safitri have another activity that she needs to do after this. So is it okay if we do documentation session now for the committee? Panitia, boleh kita berfoto dulu? Iya. Dikarenakan ada agenda lain dari Ibu Wakil Rektor, mungkin bisa dilanjutkan, kita berfoto dulu. Mungkin bisa dibantu untuk panitia men-screenshot. Okay, we are going to have our documentation sessions. So please, maybe IT, Pak Dedi or Pak Gunanto, would you like to take a picture and give a sign to take a picture? Boleh dibantu untuk difoto, Pak Gunanto?
Yeah. Okay, Ibu. We will take the picture. Okay, we will take the first gallery. I hope all participants can open the camera. We will take picture now. 1, 2, 3. Okay, the next slide. I will take the picture. 1, 2, 3. Okay, the third gallery. I will take 1, 2, 3. Okay, I think enough. Thank you, Bu Anastasia.
Thank you, Pak Gunanto.
Time is yours.
Okay. Thank you, Pak Gunanto. Terima kasih. Untuk Ibu Weni Safitri juga kami mengucapkan terima kasih sudah bergabung dengan kami. Monggo jika Ibu jika Ibu ada agenda lain, terima kasih banyak. Thank you, Miss Weni Safitri. Okay. Next, it's an honor for me to be here with 6 wonderful speakers and also all the participants that are really enthusiastic joining the webinar today. Today we will have 6 speakers, and after 3 speakers, there will be panel discussions. So please hold your questions until the panel discussions. Okay. Baik, jadi ini adalah satu kebanggaan buat saya untuk bergabung bersama 6 pembicara dan juga berada di tengah-tengah para partisipan yang sangat bersemangat untuk join di webinar hari ini. Hari ini kita akan mempunyai 6 pembicara dan kemudian sistemnya adalah panel discussion. Jadi setelah 3 speakers, kemudian akan dibuka panel discussions. Jadi mohon bagi para peserta untuk menuliskan dulu ataupun menahan pertanyaannya sampai dengan nanti di panel diskusi. Okay. My apology for the technical meeting that we face in here. Okay. Okay. We'll waiting for other participants to join in this Zoom. Okay. For the committee, is it possible to share the curriculum of the first speaker, please?
Saipuddin.
Thank you, committee.
Iya Bu, Saipuddin.
Okay. Okay. I will read the curriculum vitae of our first speaker. So we have Dr. Teguh Triyono, SPPK, SPPKK MKes. He graduated from Gajah Mada University, and also he achieved his doctoral degree at 2016 at Gajah Mada University in Faculty of Medicine. Okay, next slide, please. Okay, Dr. Teguh Triyono, SPPKK MKes. He currently held a role as a head of blood transfusion in RSUP Dr. Sarjito Yogyakarta, and also worked in medical faculty in Gajah Mada University as a head of blood transfusion services and clinical pathologist, Dr. Sarjito Hospital. And my apology, he also as a lecturer at Faculty of Medicine, Public Health and Nursing, Universitas Gajah Mada, Yogyakarta, Indonesia. Also, Dr. Teguh Triyono active in so many organizations, including as a member of advisory board in World Health Organizations. Okay, thank you, committee. Okay, Dr. Teguh Triyono MKes SPPKK will share the topic laboratory aspect of plasma donations to support patient safety. So Dr. Teguh, for the next 30 minutes, gonna be yours. Thank you.
Thank you, Ms. Anastasia, for your nice introduction. And I would like to try to share my PowerPoints.
Pak Teguh.
Okay, is this can be seen, my PowerPoint?
Yes, Dr.
I would
Teguh,
like
it's clearly
to
seen.
make it, okay. Okay. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang, good afternoon for everyone. First, I would like to thank to the committee for asking me to share this topic here in this international webinar. And also greetings to my friends, my colleagues, the other speakers, Dr. Hans Freelings from the Netherlands. This is my friends and also my senior, also my mentor as actually. Congratulations for your success WAA Congress in Turkey, and also my colleagues, Dr. Mendes Pinto from also Dr. Diratu Dia, yeah, Dr. Dia Artini, also Dr. Dia Nur Pratami, okay. And also for all of the participants, nice greeting for me that I would like to start this presentation, this sharing that with the title of Laboratory Aspect of Plasma Donation to Support Patient Safety. I would like to start this presentation with the fact or the data that this is the position of plasma donation, especially compared to the whole blood donation around the world. This is data by 2018 by WHO. We can see in the in here that especially in CRO or CR Southeast Asia region, this is the position that this is most of the donation were the whole blood donation. Only a few of this as the plasma donation. So we know that in other countries, especially in Europe, there are have the higher number of plasma donation annually. And also, if we look at the low or low middle income countries, we can see that also just a few number of apheresis or plasma donation performed than or compared to whole blood donation. And this graphic also shows us the total number of apheresis donation in thousands. For instance, or in CR or Southeast, it is also in Indonesia, I think. So only 397,000 a year. But we can see in other area, or in Europe and also in other countries, we can see there are a lot number of procedures performed annually. So this is also our challenge in our region, that we have no we have a little number of plasma or apheresis plasma procedure here in our region. Okay, then in this slide, we can see that if we are talking regarding apheresis donation, in Indonesia, we're talking especially for platelet apheresis donation. Most of our donation is platelet apheresis donation. We already perform a lot of number here in Indonesia that we perform the procedure of platelet apheresis donation here to fulfill the demands of the patient which need a platelet transfusion here, for instance, for the hematology patient, and also other situations, for instance, for dengue fever or dengue hemorrhagic fever, and also other patients that need the platelet. But now that in Indonesia, we are thinking and we are discussing concerning the plasma donation. Plasma donation using apheresis can be performed using as a plasma donation, or to fulfill or to be transfused to patient in hospital who needs a fresh frozen plasma, for instance. But also this plasma can be performed to the next process. That is a fractionation process or plasma fractionator in plasma manufacturer or plasma fractionation manufacturer for producing the PDMPs. Actually, also, if we are talking concerning the plasma or fractionation, we can also use not only the plasma donation using apheresis donation, but also we can use the source, so the recovered plasma as well. But if we use only the plasma from apheresis, we call it as the source plasma. It means that this plasma is collected as the plasma which is dedicated to the fractionation. It could be different. So this procedure already performed in many countries, but here in Indonesia, we still have what is it, had a discussion here in the country, and I know that this program would be planned to be implemented on 2024. So could be 2 or 3 years, next 2 or 3 years from now. And I think that you all still remember concerning the convalescent plasma, because we already have our experience for collecting, processing, and also distributing, and also transfusing this convalescent plasma to the COVID patient. So we can see here that in our experience that we can collect this from the cured patients, cured COVID patient, and then we process it into a plasma, as we call it as convalescent plasma, which also or have many biochemical substances in the unit. For instance, as the antibody, what is also the very important point or important fact, substance. And also we collected using there are two method can be used. First, using using the whole blood donation, but this is not really recommended. But also we perform it in many blood center and many hospital around Indonesia using apheresis donation. So we call it as the source plasma. We have our experience for collecting source plasma. So I'm just thinking that this experience to collect the source plasma could be a best or a good things for us to improve it for collecting the source plasma for fractionation. And there are a lot of advantages of plasmapheresis procedure, as also could be we have already knows. First is the volume. We can collect a higher volume, high ml, and also that the donation can be performed more frequently, could be around 14 days after the first donation. Then the donors can be redonate their plasma. And also the lower risk of anemia. Why? Because we know that in this procedure, only the plasma then be collected, but the other compartment of blood, I mean the cellular components, and also or other biochemical substance organ can be returned to the patient. So as the process or procedure of apheresis. And also because we can collect the volume with a higher ml, higher milliliter. So we can fulfill the need of a patient from one donor, for instance. So it means that we just giving a lower exposure to this patient. Exposure for infection, autoimmunization, it means exposure for antigens, and also the risk of hypersensitivity. And of course, we are talking concerning the lower contamination risk in processing, because we use automatic machine, we use a very close procedure, so we can get the lower risk of contamination. And this one is the very important, I think. We are talking at the laboratory aspect in plasma donation. It is a screening of transfusion transmitted infection, or TTI screening. That the screening of TTIs can be looked by two main categories. First is that there is a risk of, or that resulted from a chronic infection in the donor. So the donor have not been symptomatic or been asymptomatic or experience an acute illness, but could be feel very well for years post-infection. So therefore, this donor then come to donate their blood or their plasma. And most of TTIs is included in this category. For example, is the infection of hepatitis B, hepatitis C, and also HIV, and also the CMV infection. The second categories would be the that resulted in a short period of viremia, which then resolved. It means that the donor may remain asymptomatic or have symptoms or infection at the end of the period of viremia. There is no chronic phase of this infection. For example, we can find the infection of West Nile virus, also Zika virus, and also hepatitis A. So all of these, infection can be the risk in a plasma that donated from a donor, then we give as a transfusion manner, or also then we process it for the fractionation. So in two ways, we have to quarantine, or to try to minimize the risk of the TTIs. And then if we have collected the plasma, so we could also then store the plasma for several months or several years, depend on the temperature we use for storage. For instance, we can prepare or store this plasma for 36 months at below of 25 degrees, or just only 3 months at 18 to 25 degrees. And also if we use the storage machine that can store the plasma in the deep freeze or deep freeze temperature, we can store in a more or longer time, for instance, for 84 months at below of minus 80 degrees. And also this plasma can be processed also, especially not only for fractionation or direct transfusion, but can be also processed as a freeze-dried plasma that it can be used in the rural hospital or remote area or remote hospital, and also in emergency room or in ward, if can be performed. That this is a process, we call it as a lyophilization. And the clotting factors present in fresh plasma can be preserved in powder form and then stored at the ambient temperature, usually at 25 degrees or less. And then if we will use this plasma, lyophilized plasma, we can just adding the distilled water, and then we reconstitute the powder just before use. And this plasma is similar with the fresh frozen plasma regarding coagulation and also clotting factors. Just remind us that there are some indication for plasma transfusion. The treatment or transfusion for multiple coagulation factor deficiencies, for instance, for factors 8, factor 9 or 10 or 11, or other factors that can be can be found in a patient. And also for the immediate reversal for warfarin death or correction of vitamin K deficiency. And also in some DIC patient, disseminated intravascular coagulopathy, there is a very hard, I think, a hard situation. Then we need the supplement or the replacement for the coagulation factors. And also in case of massive transfusion, we call it as delusional coagulopathy. For instance, with a patient with in surgery or in accidents that a massive bleeding more than total of blood volume of this patient. So we should transfuse in a short time immediately with not only the red cell or the platelet, but also using the plasma component. And especially also for plasma exchange in some diseases, in thrombotic thrombocytopenic purpura especially, we should use this plasma component for replace the plasma that we exchange in this patient. And also as the treatment of coagulation factor deficiency, for instance, in factors 8 for hemophilia, if then we the concentrates or the medicines are not available, so can be used in emergency situation. And also the management of rare protein deficiencies can be transfused with this plasma. And also just remind that we have also some contraindications, for instance, for the situation of allergy in patient. Just remember or reminder in case of convalescent plasma transfusion, we should concern or regarding the allergy in the patient to protein, to citrate, or also patient with deficiency IgA, and also in patient with the heart situation, for example, in sepsis or thrombosis, or also multiple organ disorder. And there are, I would like to just show the one of four aspects of transfusion safety. It is the avoidance of preventable adverse reaction. So some adverse reaction can be prevented before we use or we give the transfusion to a patient. And this is the question, just could be can be found in many hospitals here in Indonesia, I think. Also, not only during the pandemic, but also before or after the pandemic. I mean, in the normal situation, not in pandemic situation. The question is, does the plasma pheresis given must have the same blood type as the recipient? This is a very, very usual question. We can get it. And you should think that we have a term of APO identical or identic APO, or APO compatible, or but non-identical. APO identical, it means that we try to find first the same blood group of the donor regarding the patient. I mean that if our patient has the A blood group, for instance, we try to find out the donor with also the same A blood group. It means that it is APO identical. For also, you can see in this picture that if the donors a donor with A blood group, that this donor have the A antigen and also the anti-B antibodies. So we can give this blood or this plasma to the recipient. With the A blood group, but we just thinking that how to then give the plasma this transfusion to other blood group, that if we we can give it to other patient. It means, for instance, this blood group giving to the O blood group, we know that the patient or recipient with O blood group have no antigen, but have the both anti-A and anti-B. But if we are talking concern regarding the plasma, or plasma transfusion, we are talking that the blood group can be transfused with all of the blood group, APO blood group plasma, because the recipient with O blood group have no antigen here, so we could not find the incompatibility here. So also the similar one for other blood group, for instance, in O blood group, if from a donor with O blood group, that we know that in this donor, he or she have no antigen or A or B, but have both antibodies. So it means that we could not give this plasma from the donor with the O blood group to other blood group or different blood groups. So you can see here in this picture that the plasma from the donor with O blood group just only can be given to a patient or recipient with also the same blood group, because this is regarding the plasma transfusion. So it means that actually the answer of the question is, yeah, could we try to find out as the first choice is the same blood group, but we can also thinking about the compatible one. I mean that it is not identical for APO blood group, but compatible. So for what I have mentioned, that the O blood group patient or recipient can be given by all of blood group plasma or plasma from all of the blood group donors, but instead of the recipient with AB blood group, because he has the antigen A and also antigen B as well, so we could not give the plasma other than plasma from the donor with AB also blood group. And this is just only a case report as an example of an incompatible crossmatch. It is a case of CHAS, we call it as CHAS or cold agglutinin syndrome. It's a rare disorder associated with infection or autoimmune disease, and also lymphoid malignancies. That it can this case was reported in a patient with with a COVID patient. Then we can get the direct COM test positive. So we can see here in the left side where the DCT or direct COM test was positive one, auto control also the positive one, and then we get, or we can find, or we look also the minor, also the positive one. But the so it is no problem. We can give it because the minor, the positive one in minor could be also caused by the direct COM test, also with the result of positive one. And the other things concerning or regarding the laboratory aspect, we also talking about antibody screening. What is the antibody screening? Antibody screening is a procedure to find out the clinically significant antibodies. It means that there are a lot of antibodies, not only A or B or D, but also other antigen, for instance, big C, little c, D, of course, and also big and little e, K, big K and little k, and also Duffy, and also GKA, GKB, and also S. And these were the irregular antibodies in the donor. So we try to minimize the risk of hemolytic risk in a patient if we transfuse the plasma. Why? Because we know transfusion of the plasma is giving a lot of volume, of plasma, for instance, 200 or 300 or 400. Could be in a dose or in divided doses. So we should concerning the release of the hemolytic reaction caused by the clinically significant antibodies. So this procedure should be performed not only for the transfusion, transfusion procedure, but also in fractionation procedure. I mean that if we collect the plasma, especially plasma pheresis, for transfusion, we should also perform this antibody screening to minimize the risk of hemolytic or other transfusion reaction, but also we try to make it to minimize risk in then we process the plasma or send the plasma to the fractionation
Recording in progress.
manufacturer.
My
And-
apology, Dr. Teguh. I just tried to remind you. Sorry for interrupting. You have 5 minutes left to present the material. Thank you.
Okay, thank you. And then we got it as the source plasma that source plasma is collected by apheresis procedure and intended for further manufacturing for fractionation, and can be performed or can be collected from voluntary or could be in some country from paid donors, but especially in Indonesia, the paid donor is strictly prohibited. So we just thinking can be collected from voluntary donors in our country. This is a plasma, especially plasmapheresis aspect of the laboratory. First is for transfusion, and secondly for fractionation. For transfusion, we should record the TDI screening, as I have been mentioned before, and also the grouping for APO and also D at minimal, and also could be in other centers in other countries also being extended, not only for APO and D, but also for other blood grouping systems, and also the antibody screening, and also, of course, for the cross-matching procedure. Especially for fractionation, we do not perform the cross-match because we just send this plasma to the fractionation manufacturer, but it is a must that we should perform first in our blood center to perform the TTI screening. Could be not only for a standard in our Indonesian Ministry Ministry of Health decree for HIV, hepatitis B, hepatitis C, and so syphilis, and could be malaria, but also could be extended for other risks of infection. And to be noted that we perform it using our immunoassay or serology method, but also using NAT method as well. The same blood grouping and also antibody screening, and also, for instance, this is important thing is the pathogen reduction, or we call it as PRT, or pathogen reduction technology. We just try to show you that first there are some methods hitting using some biochemical, for instance, for amotosalen or riboflavin, and combined with ultraviolet B or ultraviolet A light to make or to perform the pathogen inactivation or pathogen reduction, and also using methylene blue and visible light. There are some products already available, and we can use it and we can choose it. This is the concept or the basic of the pathogen reduction technology. We can perform it in platelet and plasma, and also for red blood cell component. So we use this, for instance, using amotosalen or amostalin. Then this biochemical then can intercalate it with the RNA or DNA, and then make a consistent. And finally, making the blocking for replication. It means that we can we can block contamination, and also then knock out the pathogen here. This is especially the virus. For the fractionation, it is a must perform this in all of the plasma collected. So this is to minimize the risk of infection. Then could be spreaded into patients that then can be transfused with the product of fractionation. We call it as PDMPs. This is the PDMPs. For instance, with albumin, factor 8, and other factor. And this is I think my my last slide is what already we know as well is the IVIG, I think, intravenous immunoglobulin, for instance, and also for intramuscular immunoglobulin, and also for anti-D or anti-Rho, also could be in Western countries or in American countries, that the number of the prevalence of D negative could be higher than in our country. So more usual use in that country. I think it is all of my presentation concerning some laboratory aspect or incomplete some transfusion laboratory aspect for plasmapheresis donation. I hope that this what I have mentioned can be increase or improve our knowledge especially for this topic. Thank you very much for your attention. I would back to the moderator. Thank you, moderator.
Thank you so much, Dr. Teguh Triyono. My apology because I keep interrupting you to remind as a reminder for the time.
Okay, no problem. It's okay.
Okay, thank you. What a wonderful topic that presented by Dr. Teguh Triyono. Please hold your questions, even though I know that it's really interesting topic, but please hold your question first for the participants. And we are going to go to the second speaker. It's Dr. Mendes Pinto, SPB. For the committee, would you like to please share the PowerPoint, the curriculum vitae of Dr. Mendes Pinto? Okay, Dr. Mendes Pinto, SPB. For the educational qualifications, he was graduated from University of Udayana from Bali and got the specialist program for surgery at Medical Faculty of Pajajaran University, Bandung, West Java at 2008. Next slide, please. Okay, and here is the employment record. We can see that he currently joined as a prime minister in the prime minister office and also in the private university as a part-time lecturer. He also previously also held as a director in National Hospital of Guido Valadares. Okay, is there any more slide? Okay, that's the curriculum vitae from Dr. Mendes Pinto, SPB. For the second speaker, Dr. Mendes Pinto, SPB, gonna deliver topic, the implementation of apheresis services in Timor-Leste. Okay, for the curriculum vitae, ready there? Okay, thank you, committee. Okay, Dr. Mendes Pinto, so the 30 minutes ahead gonna be yours. Thank you. Dr. Mendes Pinto, okay. Thank you.
Okay, thank you. Good afternoon for all participants, my college, my senior, Dr. Teguh, Dr. Hans. So, and I thank you for organizer, so for being invited me to be a speaker in this event. So maybe all participants never heard about the surgeon talking about the transfusion, but in Timor it's can be happen. So that's because of a limitation of our resources. We only have one clinical pathologist in this country. That's why surgeon help the other specialists. Okay, maybe I will share my my PowerPoint. Sorry. Take time. Sorry, you can see the PowerPoint.
No, still
No?
no, there is no.
So let me. You got it?
Not yet.
Not yet. Sorry.
Do you want us to share the material from here? Okay.
Possible? Okay.
Okay.
Can you help me to share?
Okay, sure.
Okay. Is there?
Yes.
Okay. First of all, so please let me introduce quickly about Timor-Leste. Maybe some of the participants don't know yet about Timor-Leste. So Timor-Leste is a small country with about 14,000 kilometers square, with the number of population around 1.5 million. So, and located between Australia and Indonesia. And in Timor, consist of 13 municipality or district. We call it municipality. It's a similar to Kota Madya. So, and one special region. And we also have only one national hospital, and 5 regional hospital, and 71 health 71 health center, and more than 300 health center, and more than 300 health posts, and 50 center for delivery, maternity. So next slide. So in blood services, I am not talking about, I talk not much about the apheresis. So I just share how the newest country are fighting, do our effort to do the transfusion services. So it's a very hard. As a new country, everything is limited. Budget, limitation of budget, human resource. So I'm just want to share with the participant. I'm not talking about much about the phrases, not talking much about the theory, but I'm just want to share with you how the small hospital with a lot of limitation are trying to do the services in the health in the blood services. So in our country, the blood services is under national hospital. So not like Indonesia. Indonesia may be under the Palmera Indonesia, PMI, but in our country, the blood services is under national hospital. So, and we providing also support for 5 regional hospital, and also private hospital and private clinic. So when you're talking about the policy structure and its collection, standard for collection, testing, storage, processing is in place, and national guided vigilance, everything is in place. So next slide, please. So supporting. So in a newest country is difficult technically, and the facilities is difficult. So we are our partner, WHO and Crossred, Timor-Leste Crossred, Global Fund, NGO, international NGO, and institutional education institution. They assist blood bank to provide the services. Next slide, please. So when you see in this these slides, the national, as I say, that our blood bank we have only 6. One in the bigger one is in the national hospital, and 5 referral hospital. But the blood bank that are able to store the component of blood and in large quantity, so only in the hospital, in the national hospital. So for the screening, we also doing a screening for transmissible infection. So we only do for 5 disease, so HIV. We screen for HIV, hepatitis B, hepatitis C, syphilis, but we don't do the screening for malaria because the government declared that the malaria almost eradicated. Next slide, please. So this is the kits that we are using to do our screening for transmissible infection. So we do a layer and Limiquid. These 2 kind of reagent or kits that we are using for screen our patient, our donors. Next slide, please. So just to quickly show you the donors. So normally the ideal is we want to have a more voluntary donors than substitute, but in fact that we substitute donor is very low compared with the voluntary donor is lower compared with the substitute one. Next slide, please. So, but in 2008, we do our effort to mobilize the people to promote people to aware that the blood donor is important. That's why the voluntary is quite increased, 36.5%. Next slide, please. Next slide. So in 2019, so when you see the total graphic, so voluntary and substitute is increased, significantly increased in voluntary. So 47.9% is significant increase. So next slide, please. So this is a component that we provide to serve the transfusion. So we are only able to do this 4 kind of component. So whole blood, packed red cell, fresh frozen plasma, and platelets. So only 3 kind of component that we are able to do. So next slide. This is just to show you the distribution of using the blood. So mostly using transfusion in medical or internal medicine. the maternity, the second place, surgery, and a lower one using in private clinic. The transfusion use blood in a private clinic is lower. Next slide, please. So this is the screening we are doing. We did in a, and this hepatitis B is a problem in the country. It's endemic. So that's why the number is high with 6%. Next slide, please. So apheresis services, I say in the previously that honestly I'm say that apheresis services is not familiar for Timor. This one is advanced services in blood transfusion. So we are not introduced yet this one. So we are planning to have apheresis services in this country, but first of all we have to prepare the resources. The resources must be training outside the country, so to prepare the human resource before we introduce. Hopefully next year we will able to introduce this kind of services. Next slide, please. So I just do some comment in my presentation. So as you know that I said before that a new country is a very difficult. It's not easy. As you know that new country, there is a lot of problem to fix. The government has a lot of problem to fix. That's why we are trying hard to complete our facility, to complete our resources. So we have to fight for that, because government, the priority is a lot of problem that government must be fixed. So that's why you have to fight for all this facility, all resources to be completed. So that's why we are fight for building. Even only building in the new country is not easy to get the building, to get the space to do the services. It's not easy. So we are work hard on that. So we are trying to do lobbying with the Red Cross, with the WHO, with our partner, and we try. And we also, lobbying with using national leader, public service, public figure to promote the blood services. So they will help us to promote, to make people aware that the blood services is very important for the patient. Next slide, please. So next slide. When you see this one, it's a very it's not appropriate place. As I say, that the new country, it's a very difficult. It's not easy. That's why I want to share with all participants that before you never see the figure, the picture like this one. And this is the old one built, and we fight hard to get this one. So even small one, but we have enough space to do the services, to do a blood services. Next slide. And I just do a little bit comment in the final, that there is a lot of challenge that we are facing as a new country we are facing. So how to review our policy, how to review our strategy, and finalize standard operational, and promote partner collaboration. That's all we are. It's challenge for us to make our effort to have all these things in place. Next, please. Next slide, please. So for future, we are committed to finalize all or standard operational. So we invite also laboratorium, our neighboring country to help to do some assessment toward the accreditation. And one thing that we are a big problem that we are facing also is the human resources. So that's why we are trying to have a partner, our neighbor, to help in capacity building. It's not easy because you need a budget to do all these things. So, as I say, that the new country is a lot of problem to fix. So a lot of priority, but we still fight. We keep fight to have all these things complete, and we still keep fight for all these things to finalize all these those things. I think that's next slide, please. I think that's all. Only what I want to share with all participants, and thank you very much for your attention.
Thank you so much for the wonderful presentations, Dr. Mendes. Thank you for sharing the situations and the implementations in Timor-Leste, and also the challenges that for the health practitioners in Timor-Leste. Thank you, Dr. Mendes. Okay, before we go to the third speakers, I just would like to remind for the participants, there is a link in the forum chat that you can click, and if you want to drop your questions, please check the forum chats. Maybe you want to drop your questions now. Buat para partisipan, silakan untuk mengecek forum chat. Di situ ada link. Kalau rekan-rekan ingin bertanya, silakan klik dan mengisi forum tersebut. Okay, now we are going to the third speaker. It's Mr. Hans Freeling, MD PhD, that will present the topic plasmapheresis, technical point and risks for donors. Okay, for the committee, would you like to help me to share the curriculum vitae of Hans Freeling? Okay, thank you. Hans Freeling, MD PhD. He was graduated from medical school and University of Amsterdam at 1985, and as graduated also as a transfusion medicine specialist at December 1998. For the work experience, we can see that he worked since 1985, and also he worked as a collection facility director in several university and also several hospital, and since for the University Hospital of Groningen since 2016. Okay, I read a lot from the website. There is several additional informations about Hans Freeling that really concern about the plasmapheresis. Mr. Hans Freeling also as a consultant apheresis and transfusion medicine department of transfusion medicine, Sanguine blood supply in Netherlands. Thank you, committee. Okay, for Mr. Hans Freeling, you have 30 minutes to present your topic. Thank you.
Thank you so much for the introduction. I try to share my screen. Can you see it?
Yes, it's clearly seen. Thank you.
Yes, okay. First of all, selamat siang to all of you. And I, similar to the other presenters, I'd like to thank the organization for inviting me to give this presentation. Before I start my presentation, I'd like to congratulate Dr. Mendes Pinto with his work, what he already achieved. This is really a challenge. I know this is my work I've done the last few years also in many countries all over the world. So you did a great job already. So thank you for sharing this with us. It's very interesting. So let me continue with my presentation. Plasmapheresis, technical points, and risk for donors. And of course, I don't have any conflicts of interest or disclosures to make for this presentation at this moment. I'm going to talk about apheresis in continuation of my friend and in Indonesia, Dr. Teguh, on technical aspects, but also on why apheresis, why plasmapheresis, and then of course about risks for apheresis. But when we talk about apheresis, you need to talk about what it is, a definition, and it's nothing else meaning taking away. But is doing a whole blood collection, is that an apheresis? No. Because what you do with apheresis is you collect your blood, you separate what you want to have, and the remainder you give back to your donor, in this case, during the process or at the end of the process, depending on the machines you have. So the question is, it is a separation during this complete donation process, and this taking some time. Now, for a plasmapheresis, you need to count half an hour, so 30 to 45, or sometimes even 60 minutes. The best separation technique was developed already a long time ago in the filter, and a long time ago, it's to be precise, in 1944 by Wilhelm Kolff, who invented the dialysis machine. But you're depending on cores, on the membrane pore, which is in the filter, and so you can't collect larger proteins from the blood, and you also can't collect cells from the blood, so only plasma or exchange of the bad substances which are in the blood. Another issue which is developed is the centrifugal techniques. And this is even older, because what you do see is that Cohn de Laval developed in 1877 already a centrifuge, but this was of course not for blood, which is developed also around the mid of the last century. But the centrifugal techniques were developed for milk, to separate cream from the milk. But still, this is an important issue. So in separation techniques, and apheresis is mainly separation techniques by centrifugal methods, what you do see is you need cells, in fact, because fluids you can't separate from fluids. That's a really difficult issue. What you need is cells. And the cells, as you see on the upper side, I don't know whether you can see my pointer. I will try to find a laser. So what you see here is cells have specific weights. And based on this, you can have, together with the radius of your centrifuge chamber, the number of rotations to go around, and the time, which is the complete blood in the centrifuge chamber, you can make a separation on that. And with this separation, you have, when you do a slow spin, so low rotations per minute, you will have plasma platelets, T cells, B cells, monocytes, the granulocytes, and the erythrocytes. So with these apheresis machines, you can, based on the specific weight of these cells, you can make your separation and collect, for instance, the platelets, or collect the CD34s, which are laid on this point for a stem cell transplant, or the T cells for the, nowadays in the Western world, rather large growing, the CD3 cells for the CAR Ts, or the granulocytes in case of infections, are also, of course, components. But when you do a hard spin, so a much higher rotations per minute, you get a very, very clean plasma. And specific plasmapheresis machines are developed, and you see them here, using solely the apheresis techniques for the collection of plasma. So we have the hemoletics machines, we have the Patinet machines, and the Nigala machines, and the Terumo machines. On the other hand, you can also use a combination of the membrane and together with the centrifugal techniques, and this is in use with the Fresenius machines, so the autopharesis C and the Aurora, which are all machines. Why is there a separation between the plasmapheresis machines and the machines that can do everything? These machines, the plasmapheresis machines, are much cheaper, so affordable in large quantities all over the world. And why should you buy a Ferrari when you don't, when you can't pass even the normal roads with Toyota or Nissan or whatever, which is maybe a tenth of the price. So we need, for this procedure, for donor apheresis procedures, we need apheresis machines. So we have, in fact, 5 larger industries that deliver these machines. So you have the hemoletics machines, which are here. You have the Patinet, you have the Patinet machine, the Nigala machine, the Terumo machine, which can also take platelets, by the way, and I think many of you use this machine for platelet apheresis, and the Fresenius Kabi machines. When I go on, we would like to talk about plasmapheresis from donors. Of course, that's the issue. And yes, it's a little bit a repetition of Dr. Tegul, but why do we do this? So we have plasma for infusion, what was named the fresh frozen plasma, to achieve larger volumes of plasma. And of course, also the source plasma, which is typically for the fractionation industry. So why are there 3 differences? And that's the technical aspect for the donor apheresis. You have different ideas on this. You have different backgrounds for this. So for the donor eligibility, what we in the Western world do, but sometimes there is not sufficient availability of donors, so you can't avoid that, is avoiding TRALI. So for FFP, for instance, we only take male donors. With the anti-HLA or the anti-HNA, which could be in the plasma from females that have been pregnant, you can give a TRALI in the patient after transfusion. The same is with travel history. So when you have been in a country where there is West Nile virus or the chikungunya virus or whatever, you should wait for 4 weeks. That's for plasma for fractionations with the source plasma not needed. Also, the female plasma can be normally used for the source plasma. Why? There are sufficient enough cells in that plasma from the pool to bind to the HLA antibodies or the HNA antibodies, but also it's enormously diluted, and then you don't have any problems with that in the plasma for fractionation. Another issue is volume requirements. So you can, what Dr. Tegul was mentioning is you can take a lot of plasma, so 600 to 700, 800 mils, I will come back to that, per donor, per donation, in fact. So this is too much for a normal transfusion. You have your standards, you have your specifications, usually based on whole blood plasma, to have, and that is also needed for the clinician. For the clinician, when you are working in surgery or in internal medicine, you want a product of which you know what it's going to do. So you want a standardized volume in that. So otherwise, Dr. Tegul spoke already about the virus inactivation. So the pathogen inactivation processes, which are needed, could be needed. That's up to your own decision, up to the governmental decision, could be needed for FFP, but are really not needed for source plasma because the fractionation itself is already two steps of pathogen inactivation. That's mandatory in the making of the process. Another issue is product quality. Do you decide, so in the Western world, and when we come to the Netherlands or we come to the US, for instance, you see that the plasma for FFP should be Lug reduced and should be red cell reduced. Red cell reduced. We know that a volume of 1 ml left, even a tenth of a ml, 100 microliters of red cells left in the product can cause NTD. So the production of NTD, which is rather important in our world. In your world, only 5 in 1,000 persons are D negative. In my world, 17 in 100, so 170 in 1,000. So we need to count with that because we don't want our ladies who should give birth to a child to get NTD. That will be really a challenge for the child. So the residual cell counts in white cells, platelets, and red cells in FFP are in our hands lower than what should be sent to the fractionation institution. So having said that, to my opinion, in every country, whatever you're doing, you should have standards or guidelines or whatever. And of course, you can take the guidelines from the WHO or the European Union or the American, so the ABB or whatever, but adapt them to your own standards. That's the most important issue. Don't take blindly the WHO standards or the European or the American standards, but look at them and adapt them to your own population. You have a complete different size than my size is. So one of the important issues what was said, and it was also mentioned by Dr. Tegul, is that there are standards of what you can take. That's the advantage of apheresis, as mentioned by Dr. Tegul. You can take 4, 5, 6, 7, 800 mils of plasma from one donation, in one donation, making it more available for the fractionation or to lower what is said by Dr. Tegul, the infection risk or the alloimmunization risk in your recipients. But safety for the donor is in the donor medicine always number one. And secondly, of course, the safety of the patient. But safety for the donor is number one. So you should not go over a specific volume, otherwise your donor will have a shock. So this is one of the most important things, 16% of the total blood volume with a maximum of 750 mils in any apheresis procedure. So keep this in mind. So we talked a lot about the infusion, and Dr. Teguh did also, of fresh frozen plasma. And mainly in the majority of country of Indonesia, I'm aware that this is still whole blood derived. In our country, none of the whole blood plasmas is used for infusion. 100% is coming from apheresis. That's also the reason that we use about 50,000 apheresis procedures to collect FFP, and the remainder is all going to the fractionation institution, and that's about 400,000 additional procedures. So going to achieve larger volumes of plasma, you do it. You did do this. So the COVID pandemic is not only one of the darkest periods, I think, of this century for the global population, but it's bringing also opportunities. You started with the collection of large volume plasmapheresis for specific antibodies, which was known already from the SARS-CoV-1, the MERS, which is also coronavirus, but also from cured Ebola patients. It's debated whether it's helped, but we didn't have anything in 2019, the end of 2019, 2020. So we started also for SARS-CoV-2 or COVID-19. And it's still in use. We still use it, we still take it. Not in that amount anymore. We did 75,000 donations in 1 year time to collect sufficient immunoglobulins for the COVID patients. But still, in immune compromised patients, it's of great help. So we still do it, and you do it. So this is for you the start. You have already many apheresis machines, and this is helping you to get the experience and being experienced and having already some technical challenges had to start with a source plasma by apheresis for the next coming years. And speaking of that, speaking of the source plasma, what you do see is this is needed. A lot is needed. Why? As mentioned by Dr. Teguh, specific clotting factors, factor 8, factor 9, the combination of 2, 7, 9, and 10, or the von Willebrand factor, or others. There's so many to mention. The immunoglobulins, the IgGs, the anti-D, the specific for tetanus, rabies, varicella zoster, anti-pox, we all did. What also is needed more and more is the C1 esterase inhibitor, and there are many others, but especially the albumin. So what we do see with the America First policy from former President Trump, that we have a shortage of all plasma for fractionation all over the world, except for in the US. So what you do see is this has influence on the availability of factor 8, of immunoglobulins, but also of albumin. So this is the reason that many governments decide to start with this, to get factor 8 for the hemophiliac patients, to get sufficient albumin for the patient care in the hospitals, and to get also immunoglobulins available for the patients. So we can make a lot of issues, a lot of things we can make from our plasma, and this is from the International, from the IFA, Plasma Fractionation Association. You see, this is being made, all of them. Well, one thing, we need plasma. Plasma, plasma, plasma. A lot of plasma, thousands of kilos, also for the whole world, this is needed. And when you see plasma, and I made this picture some years ago at our preparation site, you see this is all normal plasma. You see many different colors. You see a little bit greenish. It's not beautiful on the screen. I will show another one. Some fat, some red. This is all normal plasma, and you should have some policies on that. So this is really green plasma. Green plasma can be as green as grass, as leaves on trees, and usually this is not harmful. This is the color which is caused by using oral anticonceptive pills, some of them. That can be used, no problem at all. But you have also fat plasma. This is a whole blood I made 20 years ago already, which is a kind of mayonnaise which is floating through the vessels. And this is, of course, not that much. This one you see, but when you see the slide here, you see also. And when can you share? You should make agreement with your fractionation industry, what you can send and what you can't. What you do see here is when you put it with the label on the top, you see, in fact, you see the label through the plasma. This is agreed by the industry. Here you can't see the label through the plasma, and this is fat plasma. You are not allowed to deliver that. By the way, you're not using this also for the patient care, because I think that your patient will not be happy seeing plasma like the white one here hanging on his bed. Also with the green plasma, which is on. You have also red plasmas. That's not always hemoglobin or due to hemolysis or red cells or whatever. You have so many colors of plasma. Some specific diseases that are there that cause a little bit more red or orange plasma. So this can be completely natural. So also for all of this, you need to make agreements with the fractionation institution and policies that every center in your country do the same. So policies, procedures in the form of standards or guidelines are needed. Yes, plasmapheresis has also some risks for donors. So when you look at risk for donors, I prefer talking about adverse events. And what you do see is that what I said already, that apheresis is a process of collection, the processing, the separation of the unit you need, and the remainder is returned. So you can have adverse events in all three parts of this process causing the adverse event. So what is depending on that is type and the frequency and the severity. You have several factors to take into account. But what is important, when you want your donor to return, and your donor, your repeat donor is the safest donor, and it's the cheapest donor, in fact, because you know already ABO. You know already that the status of the transmission-transmitted infections of the previous donations. So you also know, and I would come back to that, the irregular antibodies. So you can test them already for once, and then you know the next time, and make policies that you don't need to test it every time again. So this is of importance. So when you do a collection, you take half a liter or 400 mils or 250 mils, depending on the size of your population of whole blood. You have side effects. You see hematomas, you see bleedings, you see vasovagal reactions. That's exactly the same in apheresis. So we need to take that into account. I told you we see hematomas, that's local. But we have also a vasovagal reaction, that's the complete body, so that's systemic. Or you can have both of them. So take that into account. And what is important, these events are very rare. You don't see that much events, and sometimes you see only events in 1 in 40,000 donations, or even 1 in 200,000 donations. So you need to register this. When you have always an arterial bleeding for your donation, you know there must be an anatomic variant. So register so that you can have this for the next time available on your donor center. We have immediate adverse events. Of course, whole blood is different from the apheresis, but it's depending on the volume that should be taken, or the product that should be taken. You can take red cells, even double red cells, but that's not the case in Indonesia at this moment. What we do know, but this is the cornerstone of whatever, is the return rate of the donor. And there are so many studies performed in the last 25, 30 years on this, that we want to return this donor for donor safety and patient safety. So we want to know what the effect is of a vasovagal reaction to avoid this. Make the donor convenient, give him something to drink, give him sufficient to drink. Talk with the donor. But also we know that the bruising has some effects. When you have blue arms and pain every time again, maybe you don't come back. So what we do know is that there is a high incidence. And these are from studies in whole blood donors. And to be honest, I'm now almost 40 years in this field working. I don't recognize this so much. But it's also a question of how you question it.
Excuse me, Mr. Han, my apology. I have to remind you that you still have 5 minutes ahead. Thank you.
It's okay. Thank you so much. So what I do know is that in an interview of 90,000 Red Cross blood donors in the US, they analyzed how often do they come back after a vasovagal reaction. And we do know is that 79, when you have only a little bit lightheadedness or whatever, they come back. But when you go back so 97% is a mild vasovagal reaction. 1 in 5 is not returning, and when it's happening several times, 1 in 3 is not returning. And what we do know is that when you have a moderate or severe vasovagal reactions, 1 in 2 will not return. So we need to come back. When we want to we need to avoid these reactions. This is the basics of the study. So we need to avoid them. We need to keep them in a good condition, our donors. That's also on bruises and arm pains. And what we do see is it's going to have also long-term effects. What we do see with apheresis is because of the return, you can have very severe hematomas. And this is correlated to the operator, but also to the number of donations performed. So what you do see is the first donation, the donor is afraid, stretching his arm completely all the time, all the procedure. And when you see after many donations, the donor is reading a book or watching his telephone or whatever. Also the place where you do the venipuncture is different. When you take the vena mediana, which is in the middle here, you have much less than when you take the vena basilica, which is located on the side, more on the side. So you see that. So you can see that. There are also what you see, the yellow parts in the scheme on the right side of the screen. So this is the nerve. You see nerve damage. And this nerve damage can take up years to recover, or even never recover. So some do have problems with that. We need to avoid that. Another issue is the citrate effect, hypocalcemia. And we use citrate, which is a natural something, so to bind the calcium. So the calcium steps, so the steps in the clotting system do stop when you use citrate, and when coming back in the body, it's working again because there's sufficient citrate. So you can have a hypocalcemia because of the use of plasma. But many symptoms, mild, moderate, even death of your donor. But this is very, 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 very rare. I've seen it only once, or heard of it only once, but in plasma donations, I have heard never of that. An important issue is also tiredness, fatigues. What you do see is there are some effects on the therapy. We also thought, what Dr. Teku was mentioning, okay, you never use your cells, so you give them back to your donor, so you will not have low ferritin levels. But on the contrary, what's coming up more and more is these donors can donate 20, 35 times, and every time you take samples from them. You take samples to do the ABO typing, the testing for the TTIs. And there is only maybe 10, 20, 30 mils left in your system after returning the last return to the donor. But this is not your normal hematocrit, it's of a high hematocrit. So you lose every donation again about 60 to 85 mils of whole blood. So when you do this 20, 30 times on a year base, you get low ferritin levels. Also, what's the effect of citrate? So there are some studies in platelet apheresis donors and one in plasmapheresis donors, that's my own study. What you do see is lumbar spine osteoporosis due to a chronic citrate increase. We don't see this in plasma donors because the citrate is fully resolved in plasma and is collected. So 50 to 80% of the plasma is what you use in your plasmapheresis is collected, so not returned to the donor. Then, are there some effects on the clotting and the coagulation? Well known is that there are some machines that activate the clotting system. But also what we do know is that from Australian studies that 1 in 40,000 has thrombophlebitis, and 1 in 200,000 you see deep venous thrombosis. So what effects will it have on the body of the donor? We don't know yet. So what we did see is very low IgG levels in very frequent paid donors from the US. They can donate 100 times a year, 2 times per week. There is no IgG left in this donor. What's the effect on immunity? We don't know. We need to find out. So large volumes of source plasma are needed for the factor VIII, the immunoglobulins, the albumin. We can collect them with apheresis from voluntary or paid blood donors. There are some technical challenges and there are some donor effects. So we need to have donor eligibility criteria to avoid this as much as possible. We need to have specifications for blood plasma. We need to make agreement on when the plasma is out of specifications, fat plasma, green plasma, red plasma, or having too much cells in it. And we must realize that plasma can have also long-term effects. And with that, I finished my presentation with a typical view in April in the Netherlands. So thank you so much. And I'm open for questions. I give back the floor to the moderator. Thank you.
Okay, thank you, Mr. Hans. Okay, what a wonderful presentations presented by Mr. Hans. Now it's gonna be a panel discussions. There are several questions from the participants already dropped. They already dropped from the link that already shared by the committee. For the committee, would you like to share the questions that given by the participant?
Ibu Anastasia?
Yes.
For me, my Bahasa Indonesia is not of that good that I can answer or understand it. So I'm very sure that Dr. Teguh will translate if participants have a question in Bahasa Indonesia.
Okay, thank you so much, Mr. Hans. Okay, so the first question is gonna be goes to Dr. Teguh Triyono MKes SPPK. Baik, pertanyaan dalam bahasa Indonesia, Dr. Teguh. Jadi dari Rizky M. Iskandar Alam dari Unjaya ingin bertanya perihal tentang yang telah disampaikan. Ada sebuah artikel yang tertulis bahwasannya bisa terjadi munculnya alergi pada saat proses pendonoran darah berlangsung. Bagaimana alergi itu bisa terjadi dan bagaimana cara kita menanggulangi alergi tersebut pada saat sedang berlangsungnya pendonoran? Mau sekalian dua pertanyaan langsung atau satu-satu dulu, Dr. Teguh?
Satu dulu ya,
Satu
Mbak
dulu,
Anastasia ya. Terima kasih.
Okay,
Terima kasih, Rizky. Thank you, Rizky Iskandar Alam, for your questions concerning the allergy to in the process of donation. We should think that the allergy could be not cause the process, but cause the could be the needle or and so or also could be by the side that if we context in the context of plasmapheresis, or could be by the the disinfectant fluid that we use, and also other things. So we are thinking that the allergy process could be caused by the allergy change some equipment in the process. So what should we do for this? Yeah, if we then this process that can be found. So we think that this donor have a specific allergy to a specific specific thing. So what we should do is to avoid this process. I mean that if a donor then can be concluded or determined that he has an allergy to the needle, for instance. So it is can be found again in the next donation because we use the same needle. I don't know exactly if there's any other choice for other needles, but I think that this could be the donor could not give again the plasmapheresis or the donation. So we are thinking that this is an allergy process for a donor, that it is also very specific for this donor, because every donor of the other, every donors could be different for allergy. But I think that as far as I know, could be Hans can adding for this, that just I think this allergy for the donation process or procedure would have a very, very, very low prevalence, I think. So we don't think that it is can be found easily in population. Hans, do you have any other adding for this?
Yeah, I agree completely with you. So what you do see is in fact the disinfectants being used in the donor center, the needle, so the steel of the metal of the needle, which is already very, very, very rare. And what is even more rare is ETO allergy. ETO is a gas which is being used in some by some manufacturers to sterilize the complete system, and that's also. But I've never seen it. I've never heard of it in the 40 years. So that's 20 million donations. What I was in charge of. So I've never heard of that in my country. So not it's really citrate allergy. I don't believe in that much because citrate is a natural product, even natural for your body. Think of the citrate cycle to burn it. So it's being produced by your own body also naturally. So that's it. That is the allergy.
Ya, ya. Terima kasih. Saya pernah bertemu seseorang yang alergi betadine. Tetapi tidak benar, tapi ternyata ada luka di betadine, kemudian mendapatkan pengobatan betadine, kemudian mendapatkan alergi karena betadine. Jadi memang real ya. Saya pikir kalau nanti dia donor dan menggunakan betadine, maka mungkin juga akan alergi juga misalnya. Tapi saya kira kasusnya akan sangat-sangat jarang ya. Seperti Dr. Hans bilang, kasusnya akan sangat-sangat jarang. Begitu Mbak Anastasia, mudah-mudahan sudah terjawab ya.
Baik. Ya, terima kasih Dokter Teguh. Untuk selanjutnya kita ke pertanyaan kedua, Dokter. Jadi ini bertanya tentang dari Mbak Devi Meitriana dari Rumah Sakit JIH. Izin bertanya, untuk transfusi plasma yang berbeda golongan, apakah benar-benar aman dan boleh diterapkan, serta aturan baku terkait pembolehan transfusi yang beda golongan. Kemudian untuk pasien yang hasil cross MN dan AC-nya positif, apakah aman untuk ditransfusi plasma dan bila terjadi reaksinya seperti apa?
Ya, terima kasih atas pertanyaannya. Yang pertama adalah memang ini selalu menjadi pertanyaan, bahkan di beberapa rumah sakit selalu menanyakan, tetapi dari apa yang telah pengalaman yang pernah kami dapatkan, kami lakukan ya, kita cukup banyak mentransfusi plasma dengan golongan darah yang tidak sama, unidentic but compatible ya. Misalnya tadi misalnya golongan darah O, pasiennya golongan darah O, maka kita transfusi dengan golongan darah selain O ya, plasma maksudnya ya, plasma selain O itu tidak ada masalah sama sekali. Kalaupun itu terjadi reaksi, maka terjadinya bukan karena inkompatibilitas ABU, tetapi caused by other things, other factors. I mean that. Jadi kalaupun itu terjadi reaksi transfusi, maka mungkin juga bukan karena ABO dan non ABO-nya, blood grouping-nya, bukan tapi karena hal yang lainnya. Kemudian dan ini menjadi pertanyaan cukup banyak, tapi saya selalu menegaskan kami punya pengalaman yang cukup banyak memberikan transfusion of plasma with non-identical but compatible plasma. Ini kami punya pengalaman cukup banyak bahwa tidak ada masalah apa-apa. Kemudian yang the second question is concerning the minor and also autocontrol positive. We should look also the grade of the positivity. I mean that in general, I mean that the positivity of the minor could be caused by the positivity of the autocontrol or direct contest. I mean that if we find the same result of the same grade of positive between the minor and autocontrol. For instance, the minor positive 2 and also autocontrol and also direct contest also positive 2 or even more than 2. I think it is in my experience we still perform the transfusion. We still give this plasma to the patient. And I have no experience of transfusion reaction after this procedure. But you should think if then the minor positive grading is more than the autocontrol grade. It means, for instance, the minor is positive 4 and then the autocontrol or direct contest positive 1. It means that we should think that could be the positivity grade of the minor could be not only caused by the positive grade of the autocontrol and direct contest, but could be also because of or caused by any other antibody or autoantibodies in the donor plasma. So we should think that we have to avoid this situation to give this plasma to the patient. But in other cases, then we have the same result of positivity or the what is that less result. I mean, positive 1 for minor and positive 2 or positive 3 in autocontrol or in direct contest. It is fine or okay to be given I think that it's not being not make a problem in transfusion.
May I add something, Dr.
Yeah,
Tigu?
Hans. Yeah, Hans.
I completely agree with you, and we don't take care as this is already a discussion Dr. Tigu and I have for at least 20 years or so. We never do cross matching, but we do something else. What we do is we check our donors for irregular antibodies once and after every event that could cause antibodies, so pregnancy or blood transfusion. For the remainder, we never do any cross-matching or whatever, and we give always ABO compatible, not identical, compatible. So also now in our convalescent plasma, the majority of donors, and that's because of the COVID virus, but the majority of donors have blood type A, and we use them always for all A's and O's. So we don't have almost O donors, and O donors are not of any interest, and ABs are of the highest interest, but we don't see them. So we don't do any cross matching, and minor incompatibility is for 1 or 2 units not of any trouble. So in fact, we agree with up to 1 liter in a normal sized patient. That should be agreeable, and we never see any hemolysis due to this.
Ya, terima kasih Dr. Hans. Saya kira mempertegas ya, dan satu lagi memang yang disampaikan Dr. Hans tadi itu memang pada saat kita teman-teman itu sudah mengerjakan screening antibodi pada darah donor, maka ya kita akan tidak mengerjakan minor lagi, sehingga kita tidak lagi mendiskusikan tentang minor dan autokontrol gitu ya. Jadi tetapi kalau yang kita pergunakan adalah komponen darah yang tidak atau belum di screening antibodi donor, maka ya kita masih membicarakan minor. Tapi untuk negara-negara maju termasuk di Eropa, di Belanda, mereka sudah tidak lagi diskusi no any other discussion concerning the minor. I think I know that because in other country in Europe, in Netherlands, they already perform the antibody screening for the donors plasma. So we can understand it that they have not more discussion concerning the minor, different within Indonesia. But here in Indonesia, we would like try to starting some blood centers starting to performing the antibody screening for the donor blood or donor plasma. So after that, we then know other discussion concerning the minor. Agree totally with Dr. Hans.
Yeah. So we accept antibodies, in fact. We accept antibodies in a low titer. So when the titer is below 132 or lower, we accept that. So we don't see any problems. You get an enormous dilution. And so we have never experienced, with all transfusions, we have never experienced any hemolytic transfusion reactions. So we accept that.
Okay, thank you for the for the answer, Mr. Hans and also Dr. Teguh. Terima kasih. Untuk selanjutnya pertanyaan. Okay, there is a question for Dr. Mendes Pinto from Saki from Unjaya. He's from Unjaya. Okay, did COVID pandemic affecting the number of donors, and is there any policy from HNGV Hospital Timur Leste? I believe that the questions about the policy also similar questions from Cecilia dari Unjaya, from Unjaya. So Dr. Mendes Pinto.
Thank you for the question.
Okay.
It's okay if I answer in Indonesia is okay?
Yes, please.
Oh, terima kasih pertanyaannya. Saya pikir standarnya hampir sama. Jadi untuk melakukan donor, mesti dilakukan tes screening untuk COVID-nya. Jadi kita karena banyak dibantu sama teman-teman kita dari Australia, jadi kita PCR. Jadi untuk untuk donor harus PCR negatif selama COVID. Jadi bukan karena banyak uang, enggak. Ini karena dibantu oleh dokter Teguh tahu nih, senior saya nih. Jadi dibantu oleh teman-teman kita dari Australia. Jadi kita lebih banyak menggunakan PCR dibandingkan dengan antigen yang quick test itu. Jadi kita harus negatif, PCR negatif, baru bisa menjadi donor. Saya pikir itu yang bisa saya jawab. Thank you.
Oke, terima kasih Dr. Mendes Pinto. Untuk nomor 2 juga berarti sudah terjawab. Baik. Oke, next questions for Mr. Hans Freeling. Okay, there are 2 questions. First questions from Anissa Polkesmas, urutan alat plasmaferesis yang tercanggih. Okay, so she asked about the plasmapheresis devices that you mentioned in your PowerPoint. Fresenius Kabi, Haemonelix, my apology for my spelling, Ngale, Skinomet, and Terumobicity. Which one that you recommend according to, based on the technology that they have?
Thank you for the question. That's a mean question because I'm independent. So what you do see is that Haemonetics, Nagala, and Cinemat have the same technology, which is a centrifuge chamber taking and Fresenius has a combination technology, and Terumo has a belt technology. All are good for plasma, and you can use them all, and it's up to your own personal prevalence and of course also the national agreement of the government, which machine is allowed. So I think it's not wise for me to say which I prefer.
Okay, thank you Mr. Hans. Jadi begitu ya Mbak Anissa, jadi ini tergantung dari kita bisa menggunakan yang mana saja, semuanya bagus gitu. Jadi tidak ada yang tidak bisa diurutkan seperti itu. Okay, next questions from Nur Awalia Ramadhani Salam from Poltekkes BSI. Why plasma can say antibody for human? Because there are so many ingredients in it. And what are the ingredients that cause plasma to become antibodies for COVID-19? Okay, she wrote in English. Yes.
Thank you for the question. It's a difficult question. Plasma is carrying our cells, but also all other ingredients. And the antibodies that are in our system floating around are protecting ourselves. So these are the antibodies which are in the plasma. And these antibodies can harm the recipient of our plasma, of course, because it's protection for ourselves against something else, against an antigen of another. So when we talk about COVID-19, so when we have had the disease caused by the SARS-CoV-2, so we have SARS-CoV-2 antibodies, they will also float in our plasma, and they protect us for getting infected at the same time. So, and it's helping to destroy the viruses which are still present in our body. So why the donor, what we should have is high levels of antibodies, really as high as possible for antibodies, to have sufficient titers and then it could be used as convalescent plasma and help a patient to treat the disease he's got because of SARS-CoV-2. Problem in this is that we have already many variants, and every day new variants, of course, are there. At this moment, we have the Omicron variant here, the BA.5 variant, and the beginning of this year, the BA.2 variant, which is completely different from the D variant, which was around New Year and the last part of 2021 in the world. And there are 32 mutations between these two viruses. So the antibodies against the D variant do not help against the Omicron variant. So there's a lot of things. It should be very specific for the disease which is there at this moment of a high titer. I hope that this is the answer, what is covering your question.
Boleh saya tambah sedikit, Mbak Anastasia, untuk memperjelas ya?
Baik, Dr. Teguh.
I will add something Hans in bahasa. Ya, Mbak Nur Amalia, jadi konsepnya itu bukan dalam, kalau kita bicara antibodi anti-COVID atau anti-SARS-CoV-2, maka sebenarnya antibodi itu ada di dalam plasma. Jadi kalau kita lihat darah itu kan ada komposisi korpuskular namanya, komposisi selulernya, itu sel-selnya, dan komposisi plasma atau cairannya. Nah, antibodi itu adalah sesuatu yang soluble, sesuatu yang akan terlarut ya, sehingga dia akan larut di dalam plasma. Yang produksi bukan plasmanya, yang produksi adalah sel-sel limfosit B, dalam proses respon imun. Tetapi kemudian bentuk antibodi akan terlarut di dalam plasma dan itu akan mengikuti peredaran darah seseorang, dan ya itulah yang kemudian berfungsi sebagai antibodi untuk melawan virus SARS-CoV-2 atau virus COVID-19. Jika kalau kita mengambil antibodi itu artinya mengambil plasmanya, karena antibodi ada terlarut di dalam plasmanya. Prinsipnya itu sih menurut saya ya. Terima kasih Mbak Anastasia.
Baik, terima kasih Dr. Teguh. Thank you Dr. Teguh and also Hans for answering the questions. Okay, next session is going to be, there will be a virtual souvenir that will be given by Ibu Francisca Romana as a head of Blood Bank Technology Study Program. Okay, committee just told me that there will be a virtual souvenir. Okay, Ibu Siska. Ibu Siska or Ibu Yuli?
Okay, thank you, Ibu Suci, for our speaker, Dr. Hans Leiling, Dr. Teguh, and Dr. Mendes. I want to say thank you very much for your attention and wonderful presentation for the afternoon, and thank you for sharing knowledge for us, and we would like to send you a souvenir. Please to receive it. Okay, just for Pak Hans. Nggak kelihatan ya?
I see it. Thank you so much. Yeah, I see it. Thank you so much.
Yeah, thank you, Pak Hans. And the next for Dr. Mendes Pinto. Thank you, Dr. Mendes. Oh.
Thank you.
Okay.
Thank you.
Yeah. And the last for Dr. Teguh. Thank you very much, Dr. Teguh.
Ya,
Matur nuwun sangat,
terima kasih.
Dokter. Banyak dibantu nggih, Dok.
Terima
Matur
kasih, Mbak
nuwun.
Siska. Ya, makasih.
Nggih.
Okay, thank you, Ibu Siska. Okay, thank you
You're
also.
welcome.
Okay, thank you also for our three wonderful speakers that already give the material to us, share the knowledge about the apheresis and also laboratory aspect, and also about plasma pheresis in Netherlands. Okay, we are going to have another three wonderful speakers. The fourth speaker is gonna be Dr. Dia Artini, MSc SPPK. She's going to deliver the topic donor requirements for plasmapheresis donations. Okay, for the committee, would you like to help share the curriculum vitae of Dr. Dia Artini? Okay, thank you, Dr. Dia Artini. She is graduated from Gajah Mada University, Yogyakarta, and got specialized pathology clinic from Gajah Mada University, Yogyakarta at 2015. At this moment, she works in Laboratorium Klinik Anugerah Ibu and also in Rumah Sakit Caritas Hospital Klepu. She's also as a lecturer of Unjaya Blood Bank Technology Study Program. Okay. Is there any more slide? Ada slide-nya lagi? Okay. Okay, that's the introduction for the curriculum vitae for Dr. Dia Artini, MSc SPPK. Next 20 minutes gonna be given to Dr. Dia Artini.
Thank you very much for the time and good afternoon everybody in this webinar. I am Dia Artini. Thank you very much. Alhamdulillahirabbil alamin. Respectful greetings to our parents, our teachers, Dr. Teguh, Dr. Mendes, Hans Willing. Good afternoon, and all friends and the audience in this webinar. In this time, allow me to sharing about this topic, donor requirements for plasmapheresis donation. While talking about this topic, allow me to speak English and also in Bahasa Indonesia, but there will be more in Indonesian. I am sorry because I am an Indonesian. Mohon maaf untuk panitia, apakah bisa di-share screen atau saya sendiri?
Baik, panitia, oke.
Baik. Oke, next slide please. Baik, in this topic, izinkan saya untuk menyampaikan materi mengenai plasmapheresis. Kemudian mengenai yang kedua adalah donor darah dan donor darah apheresis. Yang ketiga tentang prinsip donor darah, dan yang keempat adalah seleksi donor, dan yang terakhir adalah kesimpulan. Untuk next slide. Pada plasmapheresis ini, plasmapheresis adalah suatu proses pengambilan, pengobatan, atau pengembalian atau penukaran plasma darah dan komponennya, dan dari atau jadi proses ini berlaku langsung dari dan ke dalam peredaran darah, sehingga inti dari plasmapheresis ini mungkin tadi sudah disampaikan oleh Dr. Teguh, Hans Willing, dan Dr. Mendes bahwa plasmapheresis ini pengambilan darah, tetapi tidak semua komponen digunakan, hanya komponen tertentu, dan komponen yang lain itu akan dikembalikan ke peredaran darah pendonor. Oleh karena itu, plasmaferesis ini dapat dianggap sebagai terapi ekstrakorporeal atau prosedur medis yang dilakukan di luar tubuh. Donor darah dengan prosedur aferesis merupakan prosedur pengambilan darah dari pendonor di mana hanya komponen tertentu yang akan dikeluarkan, ya. Dan dengan alat khusus. Alat khususnya bisa dilihat di foto di samping, ya, ada alat plasmaferesis. Jumlah yang diambil tentu saja lebih banyak daripada donor darah biasa, yaitu sekitar 7 sampai 8 kali produk donor darah secara konvensional. Sebab volume produk yang lainnya dikembalikan ke dalam tubuh. Baik, slide berikutnya. Nah, sekarang kita akan sampaikan mengenai apa tujuan dari plasmaferesis tadi. Plasmaferesis terutama digunakan untuk pengobatan penyakit autoimun seperti myasthenia gravis, Guillain-Barré syndrome, chronic inflammatory demyelinating polyneuropathy, kemudian ada juga yang Lambert-Eaton myasthenic syndrome. Apa yang terjadi dengan penyakit-penyakit ini? Kenapa harus diberikan plasmaferesis? Jadi, jika pada tubuh terdapat penyakit ini, artinya tubuh akan membentuk suatu protein yang disebut antibodi. Antibodi ini sebenarnya diprogram untuk mengidentifikasi sel dan menghancurkannya. Dalam kondisi normal, antibodi ini akan diarahkan atau ditujukan untuk sel asing yang mengancam tubuh seperti virus. Tapi pada pasien-pasien yang tadi saya sampaikan, itu antibodi akan bereaksi terhadap sel tubuh sendiri. Jadi seperti musuh dalam selimut, akhirnya dia akan melawan atau berperang di dalam tubuh sendiri. Hal inilah yang akan dibendung atau dilawan oleh proses plasmaferesis. Mohon maaf, di slide ada 2 kalimat yang sama, ya, dalam kotak yang hijau dan yang lips yang pink itu ada kalimat yang sama. Di ini saya ingin menekankan bahwa plasmaferesis dapat menyetop atau menghalangi plasma yang mengandung antibodi dan menggantikannya dengan plasma yang baru. Baik, slide yang selanjutnya kita akan sampaikan mengenai apa itu donor darah dan apa itu aferesis, donor darah aferesis, ya. Sebenarnya donor darah aferesis itu akan sama dengan donor darah biasa. Di mana apa perbedaannya itu? Yang pertama di tool atau alat. Alat pada donor darah biasa yang digunakan adalah jarum suntik dan perlengkapan pendukung sederhana yang lain. Sedangkan untuk plasmaferesis atau aferesis, ya, dia menggunakan alat khusus yang dapat memilah komponen darah tertentu dari komponen darah lainnya. Kemudian perbedaan yang kedua adalah mengenai waktu atau lama pengambilan darah. Lama pengambilan darah untuk donor darah biasa sekitar 10-15 menit, sedangkan untuk donor darah aferesis itu sekitar 1,5 sampai 2 jam. Jadi cukup lama. Kemudian tentang waktu donor yang ketiga ini, ya. Tentang waktu donor pada donor darah biasa, biasanya kita lakukan 3 bulan sekali. Tetapi kalau untuk aferesis tergantung komponen yang diperlukan. Jadi biasanya kita lakukan 2 minggu setelah pengambilan aferesis yang pertama. Ada juga yang 8 minggu. Kemudian untuk kualitas komponen itu kalau untuk 1 kantong darah aferesis akan memiliki kualitas sama dengan 10 kantong darah. Jadi kalau untuk perbedaannya adalah untuk komponen darah ini, untuk komponen darah seluruh pada darah donor biasa atau yang reguler, seluruh komponen darah ada dalam kantong itu semua digunakan. Sedangkan untuk aferesis itu hanya komponen tertentu yang digunakan, sehingga inilah menjadi keuntungan dari plasmaferesis atau aferesis, di mana kalau untuk plasmaferesis komponen saja yang diperlukan, sedangkan yang lain tidak akan dikembalikan ke tubuh pendonor. Baik, boleh slide selanjutnya. Nah, ini adalah tipe-tipe dari aferesis donor. Tergantung apa yang diinginkan, misalnya platelet atau trombosit, atau mungkin menginginkan eritrosit, berarti kita melakukan erythropoiesis. Kemudian jika menginginkan sel darah putih, kita lakukan leukophoresis, dan apabila yang dibutuhkan hanya plasma, maka yang dilakukan adalah plasmapheresis. I'm sorry because there is a typo in this slide. Baik, next slide. Untuk slide selanjutnya, sebelum melakukan transfusi darah, kita selalu harus ingat bahwa kita harus memegang prinsip-prinsip dalam donor darah. Apa yang perlu diperhatikan dalam prinsip donor darah? Yang perlu diperhatikan adalah tentang pendonor itu sendiri, dan yang kedua adalah tentang pasiennya. Terkait dengan pendonor, apabila ditinjau dari aspek pendonor, kita harus melihat availability-nya. Availability itu terpenuhi kebutuhan darah. Kebutuhan darah di masyarakat seberapa yang bisa dipenuhi oleh para pendonor dalam mendonorkan darah. Jadi beberapa penelitian menyebutkan atau pernah dilakukan itu rata-rata kebutuhan darah itu dapat terpenuhi oleh para pendonor darah. Kemudian yang kedua, apa yang harus kita tinjau dari aspek pendonor adalah safety. Safety adalah keamanan. Keamanan bagaimana pendonor aman dalam melakukan donor darah. Kemudian aspek yang ketiga adalah quality. Quality adalah lebih mengacu kepada kualitas komponen darah. Sehingga ketiga aspek ini harus kita perhatikan untuk pendonor terutama. Lalu yang apabila kita meninjau dari sisi pasien ini kita harus melihat keamanan dan bagaimana efikasi atau kemanfaatan. Apakah yang dinamakan dengan safety? Safety itu keamanan, artinya proses transfusi harus aman. Dialirkan dari kantong ke peredaran darah pasien, hindari virus atau bakteri yang berpindah dari donor ke pasien. Kemudian kemanfaatan atau efikasi. Dokter harus mempertimbangkan betul jika perlu dilakukan transfusi atau tidak, karena transfusi adalah suatu tindakan yang bukan tanpa risiko. Nah, materi ini saya dapatkan dari Dr. Teguh ya, kemarin ada webinar terkait donor darah. Mohon maaf dok, saya izin untuk mengambil materi ini. Kemudian dari tinjauan aspek blood donation dan patient ini tadi, kita bisa melihat apakah lolos donor. Artinya kita bisa menjadi pendonor, tetapi ternyata donor darah, kantong donor tadi tidak, atau kantong darah tadi tidak bisa diinfusikan. Berarti kita harus melihat bahwa dalam prinsip transfusi darah itu apabila lolos donor, kita harapkan kita juga lolos seleksi. Artinya selama dilakukan pemeriksaan terhadap darah itu, dia bisa bagus semua pemeriksaannya, artinya IMLTD-nya tidak ada, HB-nya bagus, ya, mungkin bisa terkait topik yang lain. Tetapi pada prinsipnya lolos seleksi sama dengan lolos donor. Kemudian untuk slide berikutnya kita bicarakan atau kami sampaikan tentang apakah persyaratan untuk menjadi donor aferesis. Sama halnya dengan donor darah biasa, hampir mirip dengan syarat-syarat donor. Itu yang pertama adalah sehat mental dan fisik, kemudian umur minimal 17 tahun, yang ketiga minimum 3 kali sudah pernah melakukan donor darah, kemudian untuk wanita berat badannya lebih dari 60 kilo, pria 50 kilo, kemudian HB antara 13 sampai 17 gram per desiliter. Kemudian untuk tekanan darah antara 110 sampai dengan 150 untuk tekanan sistolik dan 70 sampai 90 untuk tekanan diastolik. Nadi sekitar 50 sampai 100 kali per menit, terdapat akses vena besar, dan tentang waktu donor seperti yang tadi disampaikan bahwa tentang waktu donor aferesis kedua atau berikutnya minimal 2 minggu setelah donor pertama. Sementara untuk dilakukannya erythropoiesis itu rentangnya 8 minggu, sedangkan plasmapheresis adalah minimal 1 minggu. Hal ini terkait karena perbedaan umur dari sel-sel darah masing-masing. Kemudian untuk slide berikutnya adalah kami sampaikan tentang bagaimana prosedur donor aferesis. Jadi sebelum dilakukan pengambilan darah tentunya ada beberapa hal yang harus dilakukan. Yang pertama adanya screening tentang penyakit infeksi menular lewat transfusi darah. Ini harus dilakukan ya. Kemudian diambil sampel 3-12 menit untuk pemeriksaan hematologi atau pemeriksaan darah rutin ya. Kita lihat HB-nya bagaimana, kita lihat leukositnya seperti apa, kemudian trombosit dan seterusnya. Nah, apabila 2 poin pertama ini sudah selesai diperiksa dan hasilnya bagus, pendonor bisa melakukan donor aferesis, dilakukan pengisian informed consent. Jadi perjanjian, istilahnya informed consent ya. Jadi bagaimana ada semacam perjanjian tertulis untuk pendonor. Kemudian setelah itu dilakukan pemeriksaan medis dan penjelasan seputar persiapan donor aferesis. Setelah semua siap dilakukan, aferesis donor dilakukan sekitar 1,5-2 jam. Ada ini referensi lain mengatakan 1,5-2 jam, tergantung kondisi dari tiap-tiap pendonor. Lalu setelah selesai dilakukan, pendonor harus istirahat dulu 10 menit, kemudian dilakukan sambil makan, minum susu, dan larutan ion supaya tubuhnya fit kembali. Kemudian setelah selesai beristirahat, tentunya efek samping tetap disampaikan kepada pendonor. Mungkin bisa rasa tidak nyaman di tempat penusukan, mungkin kesemutan di wajah, mulut, dan bagian tubuh lain. Nah, jika proses ini sudah selesai, maka donor darah bisa disampaikan ke rumah sakit dan ditransfusikan kepada pasien yang membutuhkan. Next, berikutnya ternyata sudah sampai ke kesimpulan ya. Jadi untuk proses aferesis ini akan melibatkan semua darah yang ada di pembuluh darah. Darah tersebut masuk ke dalam tabung mesin dan selanjutnya dipisahkan berdasarkan komponen darah. Pemisahan dilakukan dengan proses sentrifus, penyaringan darah dalam mesin, dan pemisahan komponen darah yang diinginkan dihilangkan, sedangkan sisa komponen darah yang tidak diserap kembali akan dikembalikan ke atau dikembalikan ke tubuh pasien. Jadi itulah proses dalam aferesis, dan untuk kesimpulan selanjutnya adalah ini mungkin semacam message untuk take home message bahwa buatlah suatu gaya hidup berdonor darah karena guna dari donor darah ini sangat bagus baik untuk diri sendiri atau sesama, dan terutama untuk donor aferesis adalah donor yang pada kasus-kasus tertentu. Dan sekali Anda atau para audiens sekalian jika pernah mendonorkan darah aferesis, bisa menyelamatkan 1-2 pasien sehingga nyawanya bisa terselamatkan. Dan harapan kami semua, kita semua, bahwa kalau bisa kita semua berdonor darah untuk keselamatan hidup dan orang lain. Demikian, terima kasih atas perhatiannya. Mohon maaf jika ada salah kata dalam penyampaian presentasi saya. Thank you very much and good afternoon.
Baik, terima kasih Dr. Dia. Thank you so much Dr. Dia Artini for the presentations. Okay, we are going to go to the fifth speaker. We have Dr. Dia Nur Pratami, MSc. She is head of Yogyakarta Blood Services. The topic that's going to be delivered by Dr. Dia is entitled Standard Procedure of Plasmapheresis, Technical Issues and Problem Solving for Patient Safety. Okay, for the committee, would you like to share the PowerPoint, please? The curriculum vitamin. Okay, thank you. Dr. Dia Nur Pratami, MSc. She graduated from Gajah Mada University and also attend the internship on medicine and surgery in University of Pavia, Italy, and also graduated from Gajah Mada University for her master degree, Ilmu Kedokteran Tropis. Okay. For the working experiences, she is head of blood services unit and also Dr. Teknis in Klinik Pratama, and also as a lecturer in Poltekkes Bakti Setia Indonesia. Okay. Okay, that's the curriculum vitae of Dr. Dia Nur Pratami, MSc. Okay, for the next 20 minutes, you have, my apology, you have 20 minutes to present the topic, Dr. Dia Nur Pratami.
Okay, thank you very much. Good afternoon, all the audience. Does my voice sounds clear?
Yes.
Okay, and can you see my slide presentation?
Yes, we can see it.
Yeah, okay. All right. Assalamualaikum warahmatullahi wabarakatuh. First, I would like to say thanks to Unjaya and Transmagic for inviting me joining this webinar, and my regards to all the speakers, Dr. Teguh, Dr. Hans, Dr. Mendes, Dr. Dia Artini, and Ibu Siska, and all the audience. So today I would like to share about a standard procedure of plasmapheresis. I would like to deliver this presentation in English, but some slide I would like to deliver in Bahasa. So this is the outline. First, as we know that apheresis is general term used to describe the separation, selective removal, and collection of one or more of the individual components which together form whole blood. And there are 3 points of the apheresis technology. First, the collection and the separation of whole blood. And the second, the selective removal and collection of the specific component. So if we talk about plasmapheresis, the specific component that we want to take, we want to collect is only plasma. And all the subsequent return on the non-selected component to the donor or patient. Okay. Yeah. So there are 2 categories of apheresis. First is site apheresis. So this is a selective removal of one or more of the formed cellular components of the whole blood, like erythrocyte, thrombocyte, and leukocyte. But the other one is plasmapheresis, is a selective removal of plasma, the liquid suspension medium of blood. So as you know that plasma is contents of elements that revert to fractionable components like clotting proteins and immunoglobulins that we have talked before. So in Indonesia, the government regulation of apheresis is based on Peraturan Pemerintah Nomor 7 Tahun 2011. It states that there are domain of apheresis. There are a donation apheresis and therapeutic apheresis. So for donation apheresis, it belongs to blood center units. But for the therapeutical apheresis, it belongs only to the hospital. So we should know the difference of these 2 kinds of apheresis. Yeah. Another government regulation is based on Ministry of Health regulation number 15. 2019, that plasma fractionation is separation of plasma derivatives into plasma products with applying technology in blood processing. There are 2 kinds of storage of plasma. First is recovered plasma, that we can collect plasma from the whole blood. And the other one is storage plasma that we're gonna talk today is about plasmapheresis. Okay. The technology in plasma collection system, there are 3 principal points that we want to discuss in this session about plasmapheresis. First is the automated plasmapheresis device. We will describe it after. And the process designed to gather plasma from a donor that called a collection procedure, and the single-use collection material that called disposable set. Yeah. So the first question when we start the procedure is what is required to perform a plasmapheresis procedure? First, we should check the material. We should have a disposable set for plasmapheresis, yeah, just only single use for one donor, and venipuncture materials, and also the anticoagulant solution. What kind of anticoagulant solution? Because we should consider what kind of this anticoagulant, because apheresis procedure is longer than a whole blood conventional blood donor. Okay, and what should operator need to do? First, the operator should install the appropriate disposable set. So we know that apheresis not only plasmapheresis, there are thrombophlebitis, plasmapheresis, and the other one. So we should choose the appropriate disposable set before we're running the process. And we also have to consider to modify any setting if necessary, because one equipment could be used to run thrombophlebitis and also plasmapheresis. And it's important to change the chip, because it will be different instruction by the equipment. And the other one is perform only a single venous puncture. It's much important, because when we puncture the venous, it's initiating a procedure, and plasma collection will be proceed automatically until the end collection target has been reached. So we will discuss one by one from the device component. This picture I take from the hemodynamics equipment. Okay, there are three components from this device. First, the centrifuge system. Second is the cabinet components. And the third one is the control panel. We will discuss one by one after. And we should know that this one is a bowl called Latam bowl. This is the bowl that centrifuge could be happen here. Centrifugation could be happen here. And there are two tubing here, two important tubing. The first one here, this one is the donor line tubing, and this one is of effluent tubing. The donor line tubing is the tubing when the blood donor is come from the donor's body, and the effluent tubing is a tubing for the component that we select go into the bag. Okay, first the centrifuge system. The centrifuge system is designed to hold a disposable bowl in which the blood components can span from a range 3,000 to 8,000 revolutions per minute. And the centrifugal force will separate anticoagulated whole bloods into its various components. And the other one is cabinet components. We have an optical sensor here. It's important to monitor the blood passing through the effluent tubing. So we can choose which one is this component. Is it a plasma, or thrombocyte, or red blood cell? And weigher is to measure in grams the content of the plasma containers. And we have also pumps. Pumps is used to move anticoagulant or blood, use a peristaltic movement. And we also have valves here to control the flow of the blood through the disposable tubing. And we also have an air detector to detect the presence of the air. And we also have the pressure monitor. It's a provide feedback to the system about the flow of the blood components. And also we have a control panel. It's allow the operator to interact with the system by entering appropriate data and observing the feedback. So we're gonna discuss about the apheresis principle. First is the extracorporeal blood, and second is use of anticoagulant. The third is collection of selected blood components. First, the extracorporeal blood. So in this apheresis, we move some blood out of the body from the donor. It's called extracorporeal blood. As we know, the extra is mean out, corporeal is mean corpus or body. So we move some blood into a bowl that we called Latam bowl, as I mentioned before. So the maximum extracorporeal bowl is 13% of total blood that we can temporarily move to the Latam bowl. And the second, we should consider about the use of the anticoagulant. Here in apheresis, we use ACDA, acid citric and dextrose anticoagulant. The much important here is citrate. That we know that citrate in a coagulation pathway, calcium is a cofactor to change prothrombin into thrombin and change fibrinogen into fibrin, and it can make a clot. So in the procedure apheresis, it can be less for 1 hour or one half hour. We should prevent the clots. So how we should prevent? We can prevent the clot with citrates, anticoagulants. The citrate can bind calcium into extracorporeal blood in the latam ball through the procedure. And if a citrate is bind the calcium, so thrombin is not performed, fibrin is not performed, and we prevent blood clotting during the process. Remember that the process of apheresis is not only 15 minutes. It may last 1 hour, 1.5 hours. So it's very important about the anticoagulant. So the adverse event is the citrate will entering also the donor's body along with the return blood components. So it can make a temporary hypocalcemia that Mr. Hans already mentioned before. But we should know that our body have a self-response that the calcium mobilization will happen to maintain level of plasma calcium within the acceptable limits. So in the left slide, it's a physiological state where the calcium is divided into two components. First is a calcium bond component, a calcium in bond component, and only 1% calcium in plasma. So if there is a temporary hypocalcemia in plasma, or here, the ionized calcium in plasma is decreased, so the parathyroid hormone will increase and it will make a mobilization calcium from the bone into the plasma. And it will decrease the excretion of calcium in renal. So it's important to make sure the donors that they don't have any renal infection or any renal disease history. It's the way of self-response to maintaining level of calcium plasma. Oh, sorry. I can remove the slide. Wait. Yeah, okay. Okay, the third one is collection of the selected blood component. So this apheresis, we use a centrifugation method. So the blood component will separate into 3 levels. The first one is a red cell level, also layer, and the bavicode layer and the plasma layer. So it's depends to what kind of apheresis. If we want only collect the plasma, so we just collect the top of the layer. But if we want to collect also the thrombocyte, there much different procedure. So we should remove first the plasma, and then we collect the platelet, and then we deliver back the plasma into the bowl, and the plasma with the red cell will return back to the donor's body. Yeah, but here today we will only discuss about the plasmapheresis. So this is the automated cycle of the plasmapheresis. First, the anticoagulant solution will be mixed in the disposable tubing with whole blood from the donor. And the anticoagulated blood will be drawn into a disposable collection bowl that I have mentioned before. It's called latam bowl. And the third one, the anticoagulated blood will be separated by centrifugal force into its various components. It's become 3 layers. And when the bowl reaches its collection capacity, the plasma as the top layer will exit the bowl into plasma bag, and non-selected blood components will be returned to the donor. So we will see this animation. So this one, as I mentioned before, is donor line tubing. This one is effluent tubing. This tubing is contain whole blood that mix with anticoagulant. Yeah, and this is a latent bowl. So the whole blood or anticoagulated whole blood is entering this bowl, and it keeps centrifugation along the procedure, and it will mix layers of the components. So in the bottom, the red cell layer and bovicot, and the top layer is a plasma layer. So if the plasma is reach the maximum of this bowl, so the plasma will go into the effluent tubing here, and the plasma will collect in a plasma bag. Yeah, we imagine that there is a plasma bag here. Yeah, this is the cycle that we will see in the monitor. For the plasmapheresis, only draw, collect plasma, and return. But it's different when we run thrombopheresis. It will be a draw, dwell, search, and return. So it's much different with the plasmapheresis. We will see one by one. Yeah, this is a draw step. It's a filling the bowl, anticoagulated blood draw into the bowl, and sterile air moves from the bowl into the product bag. Yeah, this is a step that collecting plasma. Yeah, so the plasma will move into the effluent tubings. Yeah, this one will move into the effluent tubings and collect the plasma.
Okay, my apology, Dr. Dia.
Yep.
You have 5 minutes left to presentation for the presentation.
Yeah.
Thank you.
Thank you. Yeah, so this is the same picture. Yeah, it keeps centrifugation, and the top layer of plasma will collect here in effluent tubing to a plasma bag. Yeah, I think that plasmapheresis is much simpler procedure than thrombopheresis. Yeah, so when a plasma is collected, the red blood cell is returned back into the blood, into the donor bodies. Also the same in this donor line tubing. So this is all of my presentation, and thanks for the attention. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Diah Nur Pratami, MSc. Thanks for the wonderful presentations. And now we are going to our sixth speakers, Ibu Francisca Romana, AMD Kes SKM MSc. She is a head of PTPDI, Professional Organizations, the region of Yogyakarta. She will present the topic, how to improve quality of donors to support quality product of plasmapheresis. Okay, for the committee, would you like to help share the curriculum vitae? Okay, thank you. Ibu Francisca Romana Sri Supatmi, AMD Kes SKM MSc. She achieved master degree in Ilmu Kedokteran Tropis in Gadjah Mada University, and currently she is a student for doctor degree in UNS Surakarta. Okay, for the work experiences, she joined the blood transfusion in UTD PMI Kabupaten Gunung Kidul and ever worked in Poltekkes BSI, and currently she works as a etika profesi as a lecturer etika profesi and hukum kesehatan in Stikes Guna Bangsa Yogyakarta, and also as a lecturer in blood services technology in Jenderal Ahmad Yani University Yogyakarta. Okay, this is the experiences of organization. There are so many organizations that she joined with it. Okay, we can see from become a vice. Okay, in technology of blood transfusion until at this moment she joined as a member in Perhimpunan Konselor VCT HIV Indonesia Kabupaten Gunung Kidul. Okay. Next slide. Okay, that's the end of the curriculum vitae of Ibu Francisca Romana Sri Supatni. And for the next 20 minutes, gonna be for Ibu Francisca Romana. The time is yours, Ibu Francisca.
Yes, thank you, Bu Suci, inviting me to the session. Hello, everybody. Good afternoon. I'm here representing professional organization Perkumpulan Teknisi Pelayanan Darah Indonesia area Yogyakarta, but saya juga dosen di Unjaya, so izinkan saya untuk menyampaikan materi terkait how improving to quality of donor to support quality product of plasmapheresis. Please, panitia, for share screen. Atau saya sendiri? Okay. Yeah, thank you. How to improve quality of donor to support quality product of plasmapheresis? Ya, saya akan menyampaikan dalam bahasa Indonesia ya, mungkin campur-campur nanti gado-gado seperti itu ya. Baik, next slide. Ya, berikut adalah visi dari Prodi TBD yang menghasilkan teknisi pelayanan darah yang unggul dan terdepan di bidang pelayanan darah, berbasis patient safety di tingkat nasional, serta mewarisi nilai-nilai kejuangan Jenderal Ahmad Yani. Next slide. Iya. Baik, sebagai kata pengantar bahwa Indonesia memiliki mimpi yang besar ya untuk membangun sebuah pabrik fraksionasi plasma, di mana untuk saat ini regulasi sudah disiapkan ya, mulai dari Permen ke-91 tahun 2015 tentang standar pelayanan transfusi darah, di mana di dalamnya ada mengatur bagaimana proses penyiapan plasma. Kemudian ada Permenkes nomor 72 tahun 2015 tentang fraksionasi plasma, di mana di dalamnya sudah mengatur bagaimana produksi dari fraksionasi plasma ini, dan juga mengatur bagaimana tentang UTD harus bersertifikasi atau tersertifikasi oleh Badan POM. Nah, selanjutnya di tahun 2017 Badan POM mengeluarkan peraturan nomor 10 tahun 2017 tentang penerapan cara pembuatan obat yang baik di UTD dan pusat plasmapheresis. Dan kemudian di tahun 2018 telah ditetapkan peraturan Badan POM nomor 34 tentang penerapan pedoman cara pembuatan obat yang baik di UTD dan pusat plasmapheresis. The next Oke, sebagai sebagai pengantar juga bahwa untuk memproduksi fraksionasi plasma atau untuk bahan bagus fraksionasi plasma itu there are three type plasma. The first recover plasma atau RP adalah plasma yang diproduksi dengan tanpa memperhatikan faktor koagulan di dalamnya ya, clotting factor. Dan yang kedua adalah fresh frozen plasma, di mana plasma ini diperoleh dari plasma segar yang dibekukan dalam waktu kurang dari 8 jam setelah pengambilan darah. Kemudian yang ketiga ada plasma frozen on 24 hours atau PV24, yaitu plasma yang dibekukan dalam waktu 24 jam dan dipertahankan pada suhu ruang, jadi antara 20 sampai 24 derajat Celcius. Kemudian dari beberapa literatur mengatakan bahwa plasma dari produk afiresis ini memiliki kualitas yang lebih baik dibandingkan dengan plasma dari whole blood atau dari plasma frozen 24. Tetapi untuk saat ini di Indonesia kecukupan produk-produk plasma ini masih sangat kurang ya untuk memproduksi fraksionasi plasma. Next. Nah, upaya-upaya yang dilakukan saat ini yaitu yang pertama adalah bahwa stok plasma untuk fraksionasi itu harus dipastikan kecukupannya baik dari sisi quantities, kemudian qualities, and consistently untuk produknya. Kemudian pemerintah dan juga Indonesian Red Cross together telah menunjuk pabrik farmasi yaitu Bio Farma untuk menjadi untuk pabrik fraksionasi plasma nantinya. Kemudian yang berikutnya adalah percepatan UTD atau affirmation blood service untuk tersertifikasi CPOB. Berikutnya adalah mengembangkan plasma pheresis center ya. Plasma pheresis center ini nantinya dapat dijumpai di tempat-tempat yang memenuhi standar, di mana nanti di pusat plasma pheresis ini plasma dapat dikolek dari pendonor yang datang untuk mendonorkan plasmanya. Nah, untuk saat ini plasma pheresis ini masih sangat terbatas di beberapa UTD yang menyediakan layanan untuk plasma pheresis ini. Kemudian berikutnya adalah memastikan kecukupan jumlah dan kualitas dari plasma untuk fraksionasi. And next. Nah, definition plasma is a protein-rich component of blood that can be used to treat a wide range of medical conditions. Nah, tadi Dr. Dia Artini sudah menyampaikan bagaimana fungsi dari plasma ini adalah merupakan sejumlah besar dari komponen di dalam darah, di mana komponen ini kaya dengan protein dan dapat digunakan sebagai terapi untuk beberapa kondisi medis. Kemudian untuk kecukupan donasi plasma ini untuk saat ini plasma ini adalah digunakan untuk terapi, namun demikian yang harus diperhatikan adalah bagaimana kualitas dari plasma itu harus sesuai dengan standar yang telah ditetapkan. The next. So what is plasma in blood? Plasma is the liquid portion of blood about 55 of our blood is plasma, and the remaining 45% are red blood cell, white blood cell, and platelets that are suspended in the plasma. Jadi plasma ini adalah mengisi 55% komposisi di dalam darah, di mana 40%-nya adalah red blood cell, dan kemudian 55%-nya itu adalah plasma. Nah, plasma itu sendiri mengandung 92% dari water, kemudian 7% protein, and 1% mineral. The next. Oke. Nah, ini ada 4 peran penting dari plasma di dalam tubuh kita, yaitu yang pertama adalah helps maintain blood pressure and volume. Jadi plasma itu dapat membantu mempertahankan tekanan darah dan juga volume darah di dalam tubuh kita ya. Kemudian supply critical protein for blood clotting and immunity. Jadi plasma ini juga membantu untuk membantu sebagai mengirimkan protein-protein untuk membantu pembekuan dan juga untuk kekebalan tubuh kita. Kemudian juga carrier electrolyte such as sodium and potassium to our muscle. Nah, plasma juga membawa elektrolit seperti natrium dan juga kalium ke dalam otot untuk mendukung fungsi otot kita. Kemudian juga membantu untuk mempertahankan pH di dalam tubuh kita yang digunakan sebagai support untuk fungsi sel-sel kita. The next. So what is blood plasma used for? Plasma is commonly given to trauma, burn, and shock patients, as well as people with severe liver disease or multiple clotting factor deficiencies. Jadi plasma digunakan untuk pasien-pasien trauma, kemudian pasien yang mengalami luka bakar dan juga pasien yang mengalami shock, kemudian juga orang-orang dengan kondisi atau pasien dengan kondisi penyakit ginjal yang severe dan juga yang mengalami gangguan dari faktor pembekuan. Kemudian plasma helps boost the patient's blood volume, which can prevent shocks and helps with blood clotting. Kemudian pharmaceutical companies use plasma to make treatment for conditions such as immune deficiencies and bleeding disorder. The next. So what to do and not to do for healthy plasma? The next. Or two, the donor drinking lots of water the day before and the day of your plasma donation appointment, ideally 6 to 8 cups water, and eat a healthy meal that's iron and protein rich within 2 hours of donation. Iron-rich foods include broccoli, beans, leafy greens, chicken, and turkey. Foods high in protein include nuts, eggs, cheese, and yogurt. Get a good night's rest prior to donating. The more rested, the smoother and quicker recovery will be. The next. So, don't drink alcohol for at least 24 hours prior to donating. Alcohol is a diuretic that can cause dehydration and make plasma donation more difficult. Jadi dengan minum alkohol, jadi jangan minum alkohol maksudnya ya dalam waktu 24 jam sebelum donasi, dan juga karena alkohol ini merupakan sebuah diuretik yang dapat menyebabkan dehidrasi. Biasanya dengan minum alkohol itu orang menjadi tidak mudah haus seperti itu ya, sehingga dapat menyebabkan tubuh mengalami dehidrasi. Dan tentu saja ini akan mengganggu atau mempengaruhi dari donasi plasma. Kemudian drink kafein in any form, dalam bentuk apapun, minum kafein itu sebaiknya tidak dilakukan setidaknya 1 hari sebelum donor plasma. Nah, ini kafein ini dapat menyebabkan caffeine can cause blood vessel to constrict, making finding a vein and returning the non-plasma portion of blood back to the donor more challenging. And next, it's fatty foods like potato chips, pizza, and fries the day of the plasma donation appointment. These foods can negatively impact for blood test and contribute to cloudy plasma. Jadi kalau kita makan makanan yang mengandung lemak yang tinggi, itu akan berpengaruh terhadap kualitas plasma yang kita donasikan, yaitu dapat menyebabkan terjadinya kekeruhan di dalam plasma itu. Jadi seperti menjadi lipemik plasmanya seperti itu. The next. Nah, so what is good to eat before donating plasma? Ya, tidak seperti donor whole blood ya. Unlike whole blood, plasma is about 90% water and 10% protein. Nah, yang terbaik adalah dengan minum a lot of water. Tadi sarannya adalah setidaknya 2 until 4 cups lebih banyak gitu ya, lebih banyak dari biasanya seperti itu. Kemudian eat protein rich foods, iron rich foods, and vitamin C rich foods before donating. The next. So drink a lot of water. Staying hydrated before the plasma donating process is crucial. Jadi mempertahankan tubuh tetap terhidrasi sebelum donasi plasma itu sangat penting karena plasma tadi mengandung 90% air ya, sehingga dengan minum banyak air, so drinking plenty of water is an excellent way to help the body recover post donation. Jadi dengan minum air yang banyak, maka ini merupakan cara yang baik untuk membantu tubuh recover pasca donasi. And then drink water extra before. Jadi sebelumnya itu minum air yang lebih banyak ya. Tadi sudah saya sampaikan sebelumnya bahwa sesuai dengan rekomendasi dari American Red Cross juga, di mana minum ekstra air 2 cup atau sampai 4 cup ya before appointment. Kemudian choose room temperature water. Pilihlah minuman atau air yang pada temperatur suhu kamar. Dengan minum air yang terlalu dingin ataupun terlalu banyak panas, itu dapat berpengaruh terhadap temperatur tubuh seseorang.
My apology, Bu Siska. You have 5 minutes. You have 5 minutes remain to present your topic. Thank you.
Thank you, Bu Suci. So the next, some blood donation center highly low sugar-free juice as a good alternative for some of water intake. Jadi selain air putih ini dapat digantikan juga di beberapa UTD itu yang menggantikan dengan minuman yang low sugar seperti itu, seperti jus, orange juice. Nah ini sangat baik untuk untuk mempertahankan atau menjaga tubuh tetap dengan vitamin C yang cukup di dalam, kecukupan vitamin C di dalam tubuh. So plasma donor should avoid alcohol which can promote dehydration 24 hours before an appointment and avoid caffeine, which can impact your pulse. The next, iron-rich foods. Low hemoglobin level can be an indicator of iron deficiency or anemia. Secara natural ya, makan makanan yang mengandung zat besi itu dapat membantu mempertahankan keseimbangan kesehatan kita seperti itu ya, dan meningkatkan level iron di dalam tubuh kita. Kemudian untuk makan makanan yang kaya dengan zat besi adalah makan makanan yang berasal dari sumber animal, kemudian seperti daging merah yang tanpa lemak itu, kemudian poultry and seafood are good choices. Tapi bagaimanapun di lingkungan kita itu banyak produksi tahu dan juga bean, itu juga merupakan sumber protein yang sangat bagus. Kemudian juga zat besi itu juga dapat diperoleh dari sumber tumbuh-tumbuhan ya, ini untuk diet vegetarian atau untuk vegan. Nah, the next. Now, protein-rich foods, eating based on protein intake slightly more before donation, 24 hours before, is a great practice when preparing for plasma donation. So always opt for lean protein like chicken and fish when possible to maximize the nutrient in meal. Other protein-rich foods include bean, shrimp, eggs, yogurt, nuts, butter, and seeds. The next. Yeah. Vitamin C-rich foods to further boost iron intake. It's foods high in vitamin C, which helps absorb more non-heme iron. This is especially important for donors who follow a plant-based diet. Some vitamin C-rich foods double as iron-rich foods. For example, spinach, broccoli, kale, peas, and strawberries. Consume plenty of vitamin C by adding bell pepper, orange, tomatoes, kiwis, and papayas to the meal pre or post donation. The next. So what's not to eat before donating plasma? Avoid consuming sodium-rich and fatty foods and drink like French fries, pizza, chips, candy, ice cream, and soda on donation day. Besides being detrimental of overall health, a high-fat diet can cause lipemia, which is the presence of the high concentration of lipids or fats in the blood cell. This can give plasma a milky appearance. Jadi seperti susu gitu ya, yang berdampak pada nanti pada saat hasil pemeriksaan seleksi donor itu yang dapat menyebabkan kegagalan untuk melakukan donasi seperti itu.
My apology, Bu Siska. You have 1 minute left.
Okay, thank you. The next. Ya, ini nutrient tips for regular plasma donor. Ya, you can read it from my slide. And the next. So how to increase plasmapheresis donation and how to keep donor to be regularly. Nah, the first, improve donor services, recruitment, selection, collection, and getaway, seperti contohnya ucapan-ucapan selamat atau ucapan terima kasih pada saat pasca donasi, kemudian ada reminder, pengingat pada saat sudah waktunya donor seperti itu, dan juga notification, yaitu seperti pemberitahuan, pengumuman tentang adanya kegiatan donasi darah di lingkungan sekitar pendonor. Nah, kemudian yang kedua, motivate donors to become plasmapheresis donor. Memotivasi donor untuk menjadi donor plasmapheresis, karena sumber donor untuk pembuatan fraksionasi plasma itu akan lebih bagus jika dari donor plasmapheresis. Berikutnya adalah educate plasma donor untuk tetap menjaga kesehatannya agar setiap donor itu dapat lolos seleksi dan sampai tahap ke collecting blood. The next, this is my last slide. So thank you very much for your attention, and time for you, Miss Suci, Bu Suci. Thank you very much, Bu Suci.
Thank you for the presentations, Ibu Siska. Okay, now we are going to go to the next session. It's going to be Q&A, question and answer from 3 speakers. Okay, there are several questions from the attendees. Okay, first question for Dr. Dia Artini, MSc, SPPK. From Jamalul Hakim, AMDKes, from UTDRS, Dr. Zainul Abidin, Banda Aceh. Oke, Ibu Dr. Dia Artini, ini ada pertanyaan mengenai donor plasma tromboferesis. Seberapa besar pengaruh citrat terhadap tubuh kita dan apakah dapat mengganggu fungsi organ tubuh, terutama hati dan ginjal, serta berapa lama citrat tersebut berada dalam tubuh setelah kita donor, dan seberapa berat rusak SDM kita setelah donor aferesis akibat putaran di alat.
Oke. Terima kasih, saya coba untuk menjawab ya. Terkait dengan pengaruh citrat terhadap tubuh, itu saya kira apabila proses pelaksanaan plasmapheresis atau aferesis ya, atau tromboferesis dilakukan sesuai dengan waktu yang sudah ditentukan, harapannya itu tidak akan merusak apapun baik terhadap ginjal maupun hati. Dan tentunya untuk berapa lama citrat tersebut berada dalam tubuh itu pasti ada waktu-waktu tertentu dan dia tidak akan lama. Artinya setelah donor aferesis itu kita diminta untuk minum yang banyak ya, artinya minum air putih terutama, sehingga harapannya semua larutan yang terlarut dalam darah itu akan hilang beserta dengan larutan yang keluar bersama air kemih, begitu.
Okay, thank you Ibu Dr. Dia Artini. Okay, next questions for Dr. Diah Nur Pratami, MSc. Ibu Emma Widiana Wangsari from BDRS Suci Hospital would like to ask, pendonor metode plasmapheresis, adakah batas maksimal berapa kali donor plasmapheresis harus dijeda dengan donor whole blood biasa? Dan apakah solusi jika terjadi pendonor plasmapheresis tangannya kesemutan saat proses pengambilan darah berlangsung? Bolehkah mengganti ke lengan satunya dan bagaimana dengan kualitas produknya?
Ya, baik. Terima kasih Bu Anastasia. Baik, mungkin yang pertama dulu ya, ini yang menanyakan batas mungkin interval antar donasi ya. Jadi prinsipnya kalau ini kita berbicara plasmapheresis dan tromboferesis. Antara plasma feresis atau tromboferesis ke aferesis berikutnya itu 14 hari. Jadi kalau hari ini saya plasmaferesis, maka 14 hari kemudian saya juga sudah bisa aferesis lagi. Dan 14 hari kemudian kalau kita mau donor whole blood itu juga bisa. Jadi hari ini donor aferesis, maka 14 hari kemudian bisa aferesis, bisa whole blood. Tapi kalau hari ini kita donor whole blood, pertanyaannya kapan kita bisa donor aferesis? Nah, itu ada jeda 1 bulan. Jadi kalau kita hari ini donor whole blood, maka kita bisa donor aferesis baru 1 bulan setelahnya. Kalau kita hari ini donor whole blood, 2 bulan setelahnya kita bisa donor whole blood lagi. Ya, jadi memang ada beberapa interval antar donasi yang harus dipahami di sini. Nah, kemudian apakah solusi jika terjadi kesemutan ya? Oke. Kesemutannya ini kita harus kita nggak bisa membedakan ya antara kesemutan karena dia mungkin posisinya yang tidak rileks atau kesemutan yang biasanya mungkin terjadi karena sebetulnya efek dari hipokalsemia temporary tadi. Kan tadi kalsium di dalam donor di dalam plasmanya dia decrease ya, turun ya. Nah, kadang ini salah satu manifestasinya juga parestesi. Parestesi itu kalau saya lebih sering menemukan sebetulnya lebih di area wajah. Saya jarang menemukan yang di tangan sih, sejauh ini belum, karena memang juga mungkin saya baru 6 tahun ya, 6 tahun aferesis ini belum menemukan. Jadi bisa saja sebetulnya parestesi ini atau kesemutan ini adalah salah satu efek samping dari hipokalsemia sementara. Nah, makanya kalau yang pernah donor aferesis, mungkin pernah dikasih minuman yang warnanya orange, ya, mirip seperti trombosit, mirip ini saya nggak sebut merek, sebetulnya itu adalah minuman yang high calcium, ya, high calcium, tinggi kalsium. Fungsinya buat apa? Buat replacement sementara. Karena tadi kan hipokalsemia sementara ya di dalam pembuluh darah ya, di dalam darah kita. Jadi replacement sementara dengan minuman ini. Jadi kalau dikasih minuman ini jangan tidak diminum, harus diminum. Walaupun mungkin ya rasanya agak sedikit strong ya, tapi ini minuman yang memang high calcium. Kemudian apakah boleh mengganti ke lengan satunya lagi? Setahu saya untuk prosedur plasmaferesis dan tromboferesis ini tidak diizinkan untuk mengganti ke lengan yang lain. Karena terutama kalau tromboferesis ya, ketika kita mengganti lengan kan sebetulnya sudah ada mekanisme tubuh untuk coagulation pathway tadi ya, dia berjalan kan mekanismenya kepada lengan yang sebelumnya ditusuk. Nah, otomatis plateletnya sudah banyak lari ke situ. Nah, kita nggak bisa dapat platelet. Juga termasuk juga plasmaferesis. Nanti jangan-jangan banyak juga darah yang kemudian clot. Karena tadi ada mekanisme clotting. Nah, ini kan kita perlu perhatikan karena aferesis itu nggak cuma 15 menit. Dia bisa sampai 1 jam, 1,5 jam. Maka tidak boleh ada darah ekstrakorporer tadi yang dia clotting. Ya, ini juga sangat penting di sini. Makanya alatnya ini juga diatur sedemikian rupa ada titrasi antikoagulan dibandingkan dengan whole blood. Seingat saya ini 1:8 sampai 1:14. Jadi titrasi antikoagulan ini memang sudah diperhitungkan supaya dia tidak menimbulkan sampai ke toksisitas akibat sitrat. Jadi antikoagulannya beda ya. Kalau aferesis itu tidak ada di dalam kantongnya sekalian. Ya, kalau whole blood kan sudah ada di dalam kantongnya ya. Tapi antikoagulannya dititrasikan seperti infus yang kemudian selangnya bergabung dengan selang whole blood itu tadi. Nah, lalu bagaimana dengan kualitas produknya? Ini maksudnya kalau mengganti lengan ya, yaitu tadi. Mungkin sudah terjawab ya. Dan satu lagi, pasti resiko kontaminasi bakterinya akan meningkat ketika kita mengganti lengan. Setahu saya, donor whole blood saja, ketika kita mengganti lengan, aturan di Permenkes, itu harus ganti sekantong-kantongnya, karena menghindari resiko kontaminasi tadi. Jadi, ya tidak disarankan untuk mengganti lengan. Kalau bisa mengganti pendonor saja. Baik, terima kasih.
Okay, thank you, Dr. Diah Nur Pratami, MSc. Okay, the third question for Ibu Francisca Romana Sri Supatni. There is a question from Devina Fatin Nurwigati, mahasiswa TBD Transfer Unjaya. Seberapa baik kerjanya pemberian terapi plasma convalescence dengan perawatan standar bagi pasien COVID? Monggo Ibu Siska.
Oke, terima kasih Bu Uci untuk pertanyaannya ya, Mbak Davina Fatin Nurwigati ya, terima kasih pertanyaannya. Ini yang dimaksudkan adalah bagaimana seberapa baik kerjanya pemberian terapi plasma konvalesen ya. Kalau seberapa baiknya ya kita memang di clinical trial kemarin itu sebenarnya kita memang tidak bisa menguji ya apakah terapi plasma konvalesen itu baiknya seperti apa, apakah kondisi pasien membaik itu karena terapi plasma konvalesennya ataukah karena terapi yang lainnya. Memang evidence base dari terapi plasma konvalesen ini memang tidak banyak dibuktikan ya, tetapi pada saat pandemi kemudian produksi vaksin juga belum tersedia atau masih limited seperti itu, sehingga untuk memperbaiki kondisi pasien itu diyakini bahwa dengan terapi plasma konvalesen ini atau plasma konvalesen ini dari pasien COVID-19 itu diyakini bahwa di dalam plasma itu mengandung banyak antibodi, sehingga harapannya dengan pemberian antibodi ini dapat meningkatkan kekebalan bagi si pasien, kan harapannya begitu. Jadi kalau seberapa baiknya, yaitu memang untuk dasar dari clinical trial kemarin juga tidak kuat, sehingga untuk terapi PK ini tidak dijadikan menjadi standar terapi untuk pasien COVID-19. Mungkin begitu Mbak Devina ya, mudah-mudahan membantu.
Baik, terima kasih Ibu Siska. Thank you so much Ibu Siska for the explanations. Okay, thank you for Ibu Siska, Ibu Dr. Dia Nur Pratami, and also Ibu Dr. Dia Artini. Okay, the next session is gonna be Bapak Reza Iqbal Suhada, APTTD, SKM, MPH, as an advisor of Blood Bank Technology Student Organizations, Universitas Jenderal Ahmad Yani Yogyakarta, will give the souvenir virtually to the three wonderful speakers. Oke, Pak Reza. Okay.
Thank you, Dr.
Thank you
Dia.
very much.
Thank you, Dr. Dia Artini. Thank you, Dr. Dia Nur Pratami. And thank you for Miss Francisca Romana Sri Supatni.
Terima kasih.
Ya, terima kasih.
Okay. Thank you, Pak Reza Suhada. Okay. Okay. Good. Now I will read the summary for the webinar this afternoon. So to sum up the webinar this afternoon about the good procedure in blood treatment for patient safety. There are several points. First of all, that we have to consider on laboratory aspect of plasma donations. And also, besides laboratory aspect of plasma donation, we have also need to consider about the donor eligibility, product handling, and product quality. And as shared in the screen, that plasmapheresis is the removal, treatment, and return or exchange of blood plasma or components thereof from and to the blood circulations. It is thus an extracorporeal therapy, a medical procedure performed outside the body. And the advantages of plasmapheresis is higher volume, more frequent donations, lower risk of anemia, lower exposure, infections, alloimmunizations, hypersensitivity, and lower contaminations. And also as I mentioned before, that 3 plasmapheresis donation variations, there are donor eligibility, product handling, and product quality. And the principles, the other point are principal blood donation plasmapheresis. Apheresis is availability, safety, and quality. Okay. Okay, thank you for the opportunity, and that's the end of the presentation from our 6 wonderful speakers. I hope the material today broaden our knowledge, especially about plasmapheresis and apheresis. Thank you for the speakers and for the participants, and I return back to the MC, Mbak Lutfika. Thank you. Baik, itu tadi dari saya untuk kesimpulannya. Saya sebagai moderator, saya undur diri, saya kembalikan kepada MC Mbak Lutfika. Terima kasih.
Okay, thank you, Miss Anastasia, for moderating this event with wonderful stage, and thank you for all speakers. Hopefully, this event give positive impact for all participants here, and we are apologize for the technical trouble today, and we wish for next webinar or event will be better than today. And before we close your event, today we would like to announce for give door prize to 5 participants. For the best question, first, Anissa Polkesma. Next, Dewi Meitana from RS JIH. Number 3, Emma Widya Mawangsari from BDRS TU CHI Hospital. 4, Jamalul Hakim from UTDRS Zainul Abidin. And 5, M. Rizky Alam from Unjaya. Untuk nama yang tertera, silakan hubungi panitia dengan nomor yang sudah dicantumkan. Then, I would like to announce the winner's name of the Student Creativity Competition by the Program Study of Blood Bank Technology, University Yogyakarta. Please the commit show for us. For the first runner-up, Naufal Afifa Rozi from Universitas Jenderal Ahmad Yani Yogyakarta. Next. Second runner-up, Putri Amalia Wulandari from Universitas Jenderal Ahmad Yani Yogyakarta. Next. For the third winner, Gloria Novana Charity from Poltekkes Jayapura. Next. And the second winner, Ariel Arnaldo from PAP Bandung. Next. And the winner is Muhammad Zaki Faridia M from Unjaya. Plisto Noberta W. Benena Dejang as head of the committee of poster competition to give certificate and trophy to all winners. Congratulations for the winner and participant competition of Student Creativity Competition held by the Program Study of Blood Bank Technology University, Jenderal Ahmad Yani, Yogyakarta. And the last announcement, distribution of certificate will be distributed on later 10 October 15, 2022. I am as Master of Ceremony. I would like to say thank you for all the enthusiasm and your attention. Finally, the webinar International has been finished. See you in the next webinar. Wassalamualaikum warahmatullahi wabarakatuh. Selamat sore, Shalom, Om Swastiastu, Namo Buddhaya, Salam Kebajikan.